All right. Good morning, PEB members. I will officially call the meeting to order. I guess they trust me with that gavel. Welcome, and it's great to see all of you here. Our meetings this year will continue to be hybrid. We just want to call out a couple of different things I think that are different from previous meetings and discussions. In this hybrid meeting format, we've transitioned from Zoom to Teams. So for our members that are attending the public meeting on Teams, our opening slide has information on how attendees can do a couple of things. One, gives you information on how you can turn on closed captioning subtitles. That process is a little bit different in the Teams feature. And also, members of the public will only be able to activate your audio and or your video during designated public comment periods. For those board members that are attending in person, remember to turn on your microphones so that folks can clearly hear you and they can capture your audio for those that are joining us online. So to start, I'm going to do a round of board member roll call introductions for those that are joining us both in person and virtually. So I will start with Elliot Weinstein. Elliot Weinstein? Is she online? She's just muted. Elliot, you are muted. Okay, maybe we'll come back. Elliot, if you get sound, just holler. Tom McRobert, Sharon Lang, Harry Bossy,
Here.
and Kurt Spiegel.
Present.
Wonderful. Thanks, Kurt, for joining us online. All right, Elliot, any more from Elliot? All right, we'll just keep moving and hopefully the audio comes into to bearing. Also, just want to welcome Michael from our Attorney General's office who's here too.
Thank you.
Yep. It is a privilege and a pleasure to be able to step into the role as not only the chair of PEB, but also the director of the Healthcare Authority. I've been here since August. Just a little bit about me for the board members. My background, I grew up in rural coal country Appalachia in West Virginia, a town of 84 folks. 83, I left it. And I've been on a path to sort of try to remove as many barriers for people to access healthcare as possible. And that's a culmination of a career both in and out of hospital systems, community health centers, mostly in Baltimore, Maryland, and the Washington, D.C. area. And then before coming to the state of Washington, I served as the state's Maryland's Deputy Secretary of Healthcare Financing and the state's Medicaid Director. And it is just a pleasure to be able to join Washington. This particular work, not only of a matter of just because I'm a healthcare policy wonk and appreciate the world of healthcare coverage and what that means and the importance of what that is, but it's also very personal. My father retired as a Medicaid caseworker in the state of West Virginia, so understand the importance of public employee benefits. And then I've got a school of educators, and I use that term intentionally, around us. Mom also is a school secretary in my hometown, so understand the importance, benefit of that. Brother's a bus driver. So this work is critically important and touches me personally. So I am just thrilled to be able to step into the role of chairing this important work. And I also, in the 6 months that I've been here, just want to thank Dave and the PERB team, who just are, as you all know, are just an exceptional group of people who demonstrate a level of professionalism, attention to detail, organization, and I've just been incredibly impressed by all of their due diligence and their leadership. So thank you, PERB team, and it's I look forward to getting to know the boards closer, if you will, over the course of the time that we have together, and thank you so much for your warm welcome. I'll just note we're going to start on the agenda of the conversation for today. So for all of the board that's either here in person or virtually, if you can hold your questions till the end of each presentation, or if the presenter pauses and asks questions, then that's a fine time to interject and ask questions. Board members virtually, one other logistics moment. In the feature of Teams, there is a raise your hand feature. And that is going to help us indicate whether you have a question and so that we can call on you. So we would ask that you find that raise a hand feature and use that. I'll note up front that for today's conversations, there are no resolutions that are scheduled for today's retreat. And the public is able to provide comments at the end of the meeting during our designated public comment period, as I mentioned. For those participants that are joining us online that want to entertain the portion of our public comment period, we'll also ask you at that time period to use and raise your virtual hand, and we will call on you once we see that your ability to turn on your audio and your visual at that time. All right. Also, just as a note, in the spirit of open and transparent government, the presenters' contact information after each of the presentations and slides are also listed. So if there's any questions that any member of the board or the public has based on any of the content, that is there for the use, so that you can capture your questions and receive a response from the agency. So with that, I am happy to turn it over to Dave, who's going to provide even more of a detailed review of the agenda. Dave, thank you so much, and thanks for your leadership.
There we go. Good morning, Chair Moran and members of the board. First, I want to check in on Elliot, who might be unmuted, and see if her audio is working.
Hi.
Hi, Elliot. Yep, we can hear you now.
Hi. I'm here.
Perfect. Thank you, Elliot. Just wanted to make sure that we had your audio working. Glad you are here and on the record with us. So today, it hardly feels like 6 months has passed, but it has somehow, and we're back together. Time flies here at the state and at HCA and our programs in particular. I always think of the retreat as we're going to travel through time in the past, present, and future. We're going to revisit the fall open enrollment and the results that happened in the near past. Then we're going to talk about what's happening over at the legislature and with the governor's supplemental budget and the budget process that is unfolding right now. And then we're going to talk a little bit about the future, because we've been spending a lot of time talking about our IT systems and where we need to go and giving updates on IT. So that's a lot of the flavor of the day. I do want to do a couple of other housekeeping pieces. Just a reminder for everybody here in person: if you need the restroom, walk down the hall. If you see elevators, look to your left. If we have an emergency and need to evacuate, we're going to walk purposefully across the street into the visitor parking lot that I'm pointing to. And everybody who's here can see where I'm pointing. So that's where we're going. Last, I want to share a couple of updates about the board itself. You may have noticed, if you're counting, that there are 6 of you here today, and we historically have had 8 people who are part of our board. First of all, Michaela Dolman has completed her time serving on the board, and the governor's office is working on another appointment for her successor from someone who's in current state HR leadership. We're anticipating that Travis Eberly, one of the deputies over at state HR, will be joining us. He wasn't able to join today, and his appointment's not finalized either, but once that is completed, he should be joining us the rest of the season. Additionally, in a few moments, we'll talk about John Comerford, but with his passing in November, the non-voting position is vacant. The plan at this point is to leave that non-voting position vacant as a very small contribution to some of the administrative savings for the program during our tight fiscal times. So those are just kind of updates about the board itself. Any questions on that or today's agenda? Right. Well, then I wanted to take a few moments and have us talk and remember John Comerford, who passed away this past November. So John served on the PEB board for 6 years. It didn't feel like it was 6 years, but he joined in 2020 right before the pandemic started, and has served with us through the end of last season. I think of John, he always had a keen eye for retiree issues. He was clearly an avid reader of the news, often preempting some conversations that we'd even started here at the agency about things that might be happening federally. And so he was definitely, I'll use Ryan's words, of a policy wonk. He was a federal policy wonk for sure, and certainly here in the state as well. We also know that he enjoyed traveling in his retirement. He was one of our more judicious member uses of our hybrid meeting format. I think my favorite place was the cruise ship, where he was somewhere in the maybe near Arctic. I was like, wow, I couldn't even get Wi-Fi to work when I was on a ship, and you're in a board meeting here. Great. So just always found that a bit humorous that we knew he was zooming in from somewhere, and also appreciated when he was here in person. So I was those were things we did know about John. And unfortunately, it's a reality that we often learn more about people after they pass than some of the things that we didn't know about their career. So I thought I'd share a little bit. I think it was pretty obvious that his career and his interest centered a lot around financial and health and human services and those types of industries. He simultaneously with PEB served on the Washington Economic Development Finance Authority, so working on a variety of different finance policies here in the state. He had a lot of different gubernatorial appointments, but one of his earliest appointments was actually by President Carter, when President Carter appointed him as the founding president of the National Consumer Cooperative Bank, which was an entity that was designed to help support the growth of co-ops around the country, improving their access to credit, loans, and those sorts of things. It was originally chartered by the federal government and propped up by the federal government before it became more privately owned and private in the early 80s. And I always I picked that out as I thought it was just something really interesting that was in his past. And plus, I can't help myself. So when John was starting that work, Pay One was an infant. And it was our burgeoning accounting technology here at the Healthcare Authority. So I always try to juxtapose things that happened in the late 1970s. So I just thought that was just interesting about his service. I know John was really eager to join the board this season. He actually reached out to me and we had a conversation about the upcoming board season just about 2.5 weeks before his passing. So he was still really engaged and very interested in the work. So I just want to thank him publicly as such a dedicated public servant. And I just wanted to offer up any other opportunities for board members to share comments about John at this time.
Yeah, Dave, I'd like to. I think I was the non-voting member when John came on, so I got promoted to. And so I kind of walked him through the ropes, as it were, but we developed a friendship over those years, and because we're kind of the same age group, and we are displaced New Englanders, Red Sox fans, and so there were a lot of things we found out that we had in common over the years, including some friends who, unfortunately, we weren't able to ever get everybody in the same room together. Well, earliest thing I remember from John was he told me about one of his uncles, whose name was John Gilhooly, which means nothing here, but he was a writer for one of the Boston newspapers when I was growing up. And I used to read his column all the time. And it was John's uncle. And so how small a world is this? So I'm deeply saddened by our loss of him. And he had told me last summer they had had some issues, but they were improving. And so that was good news. And then, of course, we got the shocking news a few months ago. So, but he was a wonderful man, and I miss him, and I know everybody does. Thank you.
You know, I'm a teacher. I really don't need a microphone. I could project my voice. Anyway, so, and then the other thing was when he got to know him here, he always, when he would come in and he'd have a twinkle in his eye and he'd always come up and greet you and tell you what's going on. And Harry and I and John would have these little conversations. We were actually talking about meeting for dinner the day before some of our meetings. That was kind of at the end of the last season. So yeah, I will miss him too. He was really a good addition and very insightful too.
Just want to check online as well. Kurt, I think you had your hand up.
Yeah, I was just gonna say that we couldn't hear Tom.
Oh,
but
okay.
when he fixed it, yeah, but he fixed that, so that was
His
it.
teacher
Thank
voice
you.
didn't project across time and space, just in the
Right.
room. Got it. All right. Well, I thank everybody for kind of taking a moment to talk about John and again honor his service here with the board. I had forgotten he grew up in his upbringing was in Boston. I never made that connection until you said that, Harry. Between you and your image is always the Green Monster, so it's Fenway Park. So thanks for everyone for sharing some comments, and then back to you, Ryan.
Sure. Thank you, board. Although I didn't know John, I always think just from reflecting from what you all have shared, and anytime we lose somebody, may we be open, maybe be guided by John who's come before and open to that, which is yet to come because of him. We're now going to transition to talk about a roundtable discussion on policy impacts related to healthcare cost, access, and quality. And we're going to start off our educational panel discussion. I think John's going to come forward. John serves as our benefit strategy and design section manager in our ERB division. And we have, I think, 4 panelists, 3 panelists, 6 panelists. Okay, so see, this is why I'm not in charge. 6 panelists who are here to provide a really thoughtful dialogue and enlightened dialogue on sort of the dynamics that are happening in healthcare. Also, I think, as all of you know, if you're reading the front folds of any of your newspapers, this is a challenging time that the healthcare ecosystem finds itself in. And so bringing in some external voices to try to guide the board's foundational discussion and thinking about this for the next year, sort of the purposes of this panel. And so with that, I will turn it over to John to facilitate.
Thank you, Chair Moran. Thank you, board members. Looking forward to this. We're very fortunate to have a number of industry experts and some different perspectives and insights that they can each share. I want to introduce folks really quickly. Starting at the end, we have Dr. Ty Jones, who's from Regents. He's one of their medical directors. We have Dr. Ward, who's from Kaiser Permanente, Senior Medical Director. Dr. Ankeny, also from Kaiser Permanente, Senior Medical Director. And then we have Sheila Tallman from United Healthcare and Michelle Volrath from United Healthcare, who are executives in the external affairs and client management arenas. So very fortunate to have very different perspectives. Folks from United, obviously more focused in this context on Medicare. So if we have questions as we go through that are related to Medicare, I appreciate their support in being able to address those. So with all that as background, I'll start by just kind of setting up the context. As Chair Moran suggested, we're going to talk a little bit about changes that are happening at the federal level from a policy perspective and where there might be some incongruities with things we're doing at state levels and how those things impact the availability of care, access to care, and the cost. So I'll start just by kind of opening a very open-ended question to our panelists about what kinds of things, when you think about that big picture question of what's going on at the federal level that impacts availability of care and cost at the state of Washington level, what kinds of things do you see that either they could be concerning, they could be, hopeful, opportunities? What kinds of things are front and center for your minds as you're thinking about how care gets delivered and how much it costs in the state of Washington? Anybody care to jump in? Dr. Ward?
Well, thank you for having me. I think I start by answering that question. First, Kaiser Permanente is rapidly trying to understand the new executive orders, just like all of us, and what that means. But there are a few significant trends and changes that I would speak to. And I'd start with maybe 3 concerns, but then I'll quickly get to some solutions or some hope for next steps. I think, one concern when we look at access and to care is just to candidly say those enhanced subsidies and premium tax credits that expired in December. And as far as I've seen, I haven't seen those continued by Congress. That is a big looming issue to us because when that expiration, it's going to make it harder and harder for more Washingtonians to afford care. And so that's going to mean more people go without the right care in the right environment, and that's going to increase costs, and that's going to impact kind of all lines of business, Medicare, Medicaid, and commercial. I just get to notice we're all hoping for this personally, but the U.S. population is aging at an accelerated pace. Historically, that's come with more healthcare costs and needs. And then I also want to note that there's an increase in kind of overall patient acuity. So we're seeing younger generations in their 20s seeking more medical care than previous generations. And there's upside to that. I think about, a young 20-year-old reaching out for care around anxiety, and there's also costs associated with that as well too. So those are some of the concerns that are front and center on my mind, and then quickly moving to some solutions, because I think that's why we're all here to try to think about what's next. I just double down and say, number one, prevention, 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 and putting some numbers behind this. When we catch someone with colon cancer early, scary diagnosis, but when we catch it early, boy, that's a much better personal journey, right? It's less chemo, it's less radiation, it's a smaller surgery. All of us would want that for ourselves because that medical treatment is much better than when it's caught later. When we catch it early, we also save $86,000 per person. So to me, that is like real savings in numbers that we can put towards solutions. And, we can get into as much or as little this as we want, but historically it's been, you got to have a colonoscopy, which is a great test. It really is. And it's a really extensive test. You got to be put to sleep. That's a good thing. And you got to have a team monitoring you and the whole piece. There's a test that is for most Washingtonians, not all, but for most, is just as good to have a simple fit test. Now, it's an immunochemistry test. It can be mailed to your home on your birthday. You can do your personal business and send that back in without the whole thing. And that is just as good as long as it's done every year. That's another cost-effective way to get that screening done early, on time, and save dollars. So that's why I say prevention and put some numbers. The second one is just right care in the right place. We're just persevering on how do we keep our patients out of the hospital, out of the emergency department. We need good hospitals and we need good emergency services, but how do we keep our patients healthy and as possible? And then third, I would just say community solutions, community solutions. Our communities know what the needs are locally, right? Because we just acknowledge that most of healthcare occurs outside of the four walls of the exam room. I'm a physician, very proud of what I do, and most of healthcare is upstream of that. It's good housing, right? It's access to good food. It's all access to really good exercise. All those pieces that drive health that is outside. It's why we're so committed to donating to these community programs that know what the needs are locally and are able to use those local resources even more efficiently. But I have to highlight that community solutions is an important part. So those are just three areas that I think we could really focus on to try to help in this situation.
Thank you, Dr. Ward. Anybody else have anything they'd like to start with? Yeah, Dr. Jones.
This is my year for a fit test, by the way. It's happening.
I think
Thank you for
doctors
the
and I
reminder.
celebrate birthdays differently.
Yeah, it's a milestone. So I'll share a concern. So I'm highly concerned about the funding that's been pulled out of our state ecosystem by the Medicaid cuts and OB3. So $1 trillion is expected to come out in total across the country. About 37 billion, I think, is estimated to come out of Washington State. So where that funding is going to be cut, that's programs directly to hospitals and hospital systems, or pardon me, funding that was funding those programs. That's in folks losing their insurance altogether, and that's a reduction in how much Medicaid is able to reimburse for services at the same services at those providers' places. So it's easy to think when you hear Medicaid cuts, that's going to affect, well, members on Medicaid. But that really is pulling money out of our entire medical community. If you're commercially insured, using Medicaid, using Medicare, you're probably using the same hospitals. You're probably seeing the same providers. You may have the same mental health provider serving you. And so that affects everybody. And when those hospital systems and providers have less funding, they're going to either have to find the revenue somewhere else, or they're going to have to make cuts. They're going to have to do less with less. So first, I think relevant to this group is that first topic where they're going to have to find the revenue somewhere else. And I'll give an example of a hospital that, let's say Valley Medical Center. They had 100 million in cuts in programs last year, and that is a safety net hospital. They don't have $100 million sitting around. I mean, that's like a 6-figure CEO salary as opposed to a 7 or an 8 elsewhere. They're doing what they can. And so to make up for that $100 million, one place they can make that up is negotiating with commercial insurances to ask for higher rates for the same services. So that can be passed on to a commercially insured program. In terms of access, when faced with less funding, there's a few different places they can go. So you can freeze hiring, or in their case, they eliminate 101 roles. They can look to shut down clinics, which in their case, they shut down a primary care clinic in Kent, a primary care clinic in Renton, also an urgent care. And those clinics served members with insurance, across the board. They may look to cut entire specialties out that are low margin. So in their case, they retired their pediatric neurology program. They no longer have a maternal fetal medicine program, so are no longer able to handle high-risk pregnancies at that location. Or they may have to eliminate entire hospital service lines, so they no longer have a pediatric inpatient service. And why that's personal to me, I work for Regents. I think I have nice insurance. When my own 1-year-old had bronchiolitis 2 weeks ago, there would have been a time. So I did my residency at Valley. I took care of babies with bronchiolitis. That was no longer a place for her there. And so my wife and I were doing the 3-hour round trip to Seattle Children's, which I'm so grateful to still have that care. I mean, it still is a wonderful option, but to manage our 4-year-old and our 1-year-old for what turned out to be 8 days. And that is a direct result of Medicaid cuts affecting our access to care in our locale. Thank you.
Thank you, Dr. Jones. Any other inputs before I have some follow-up questions from those?
Thank you. So it's Michelle Volrath from United Healthcare. I'm going to specifically focus kind of on the Medicare Advantage plans, and they've not been in the news at all, right? So I think with Medicare Advantage, I think the constant for us has been change over this administration, but also over the prior administration. There's been such a significant amount of change, and with change comes constant concern by retirees. It becomes a concern about where those costs are going, if costs are being pulled out of the federal funding, and it becomes very confusing for retirees, right, as plans are pulled or changes are made to benefits, et cetera. So that's obviously a huge concern of ours, and we continue to dive in and advocate on behalf of our members, but also on behalf of Medicare Advantage overall. Over 50% of the retirees across the country are in a Medicare Advantage plan. So that's why it's become such a focus of the administrations over the last 8 years. And so we continue to really advocate on behalf of Medicare Advantage and hopefully getting to more of a constant state so that we can all manage the changes that have occurred and be able to figure out how to continue to provide the right care at the right time for those members and give them the optimized health. But more, and I also feel like getting to kind of the community phases, et cetera, care in the home and house calls and those types of programs that are part of those programs are key to that success. Continuing to be able to not just see the member in at the office, but making sure that they have access, checking on equity issues, and being able to get out to rural communities and check in the home and then be able to share that information with their providers is key to the success of the program as well. So we continue to invest on those pieces.
Yeah, thank you. And so we'll come back to the rural community piece in a moment. I appreciate you giving me a nice segue into that, but let's hold that thought for a moment. Any other immediate comments before I start the follow-up questions? Okay, so one of the things, Dr. Ward, that you mentioned was younger populations starting to seek more care and a change in acuity of patients related to that. And I'm curious, two things. Number one, the types of services I would expect, because the acuity is different, are very different. So if you could expand on that a little bit, others feel free to as well. But also, what does that mean from an access perspective? As more people start to seek care, we've got this constraint of the funding and the reimbursement for in some ways. What does that mean for availability for folks getting in to see a primary care physician for a variety of concerns or issues?
Yeah, that's a great question. And I think the way I'd answer that question is it's both things. There's good and tough pieces of that. So for example, we have more kind of complex chronic disease happening that is noticed in younger Americans. And so I'm talking about, rheumatoid arthritis, ulcerative colitis. These kind of complex chronic disease have some actually really interesting treatments, right? And those treatments tend to be very, very expensive. And so we can talk later about pharmaceutical solutions that I see around that. But just the point of there is more chronic complex disease that does drive cost. And I'll get to your question, tie it in with access. And then I just do want to celebrate, though, there are good things. So like I talked about earlier, we want the right care in the right place when, for example, mental health. I think younger generations have, at least in my opinion, have a little less stigma and are more apt to coming in and taking care of their mental health earlier. I think that's a great thing. And so how can we as medical systems really capitalize that and give the right care in the right place? Quick story on that. We have a collaborative care model. And so what that means is that as a primary care physician, I have access to a team, and I'll explain it a little different. If a patient notes that, hey, they're struggling with anxiety or depression or thinking about harming themselves or, really complex things, I can immediately pull in a team of licensed mental health professionals that can really start working on tactical solutions right then. And that's a great way to really work as a team to really solve those things. The quick example on anxiety is whether you're connecting with resources like the Calm app. I use it myself. It's a really cool app with world experts teach some strategies on this, or whether we're connecting with a psychologist or connecting with community resources or just going over some coping mechanisms. Those are great ways to get ahead of potential, hospitalization, really harmful things down the way. So that's the positive around this, but also, just the candid of the cost of chronic disease. And so, we are continuing to seek ways to innovate, to have these right teams on place because it is asking for a lot of visits, right? There are more visits than before. So just some quick examples, and we don't have to memorize the numbers, but when I started this, it was around, that group saw it about 1.6 visits per calendar year. Now it's up to 2.4 and higher. So this is a markedly increased request of visits. And so, it's a strained system with not a plethora of doctors and nurses. And so it does impact access. And that's why I mentioned the collaborative story specifically. That's a way to innovate. It doesn't all have to be the doctor's office visit. It can be the doctor's taking care of that rheumatoid arthritis, and the mental health team is taking care of some of these mental health needs. That's just an example of, I think, how to thread that needle between increased access and how to take care of our communities.
Dr. Ankeny, please.
Yeah, just an additional thought. David and I are both practicing doctors. This isn't actually what we do all the time. And one thing that comes to mind as he was talking is that I believe this is occurring regionally, but I know that at Kaiser Permanente, there's been a pivot back toward primary care as well. And there's been a bit of a swing and a miss, I think, in the medical community over the previous decade or so, that we've really become increasingly specialist dependent. And there is better access fundamentally at the primary care level by definition. So when we're talking about increased access needs, a really salient question is, how much of this can be handled by primary care, and how much of it can be better? Can primary care be buttressed by specialty care, but doesn't actually require the patient going to the specialist? So you mentioned rheumatoid arthritis, for example. David and I don't think you do. I don't start meds, high-level biologics for rheumatoid arthritis as a primary care doctor. But it doesn't mean that I can't manage those. And if I have my patient see, or if I have access to a rheumatologist as the doctor, and we can have a discussion between the two of us about how best to start this process and get this patient taken care of, that patient can just stay in my office. And I can just manage that. And then when I need to talk to rheumatology, I can. So, I'm enjoying the pivot that our organization is making back toward that, a greater commitment toward primary care with a support coming from specialty, instead of thinking, how are we going to get all these people into rheumatology and psychiatrists and all the different specialty clinics that have much, much less access. So.
Dr. Jones?
Plus one, a comment about meeting patients where they're at. As you mentioned, younger folks are presenting for care sooner, which is great. I mean, I think there was a time where it was very difficult to get somebody after their well child checks until, well, they were having a kid and thought it's time for me to pull it together. I think we've also seen an uptick in like higher quality virtual solutions. Like at one point, having a virtual doctor visit might have meant just urgent care, but there are increasing like higher quality primary care products out there, which are really something that's easy to wrangle. Or sorry, it might be easier to get say somebody in their 20s to go have a virtual visit, at a break at work, than it is to go through all the other scheduling. So I think for at least on the health plan side, like being able to offer some of those solutions and making those links can be very helpful to getting the foot in the door.
Following up on two things here, Dr. Jones and Michelle, one of the things that you mentioned about health in rural communities and access in rural communities. Ian Corbridge couldn't be with us today, but he's from the Department of Health and works on the community health systems. He's the director of the Office of Community Health Systems. And in our discussion last week, he raised a point of one of the changes he's seeing, and there are myriad reasons for this. We'll come back to this in a few moments. But one of the reasons is what's going on at the federal level related to tariff pricing, right? And that it's causing changes in capital investments, capital projects, and delaying capital projects just because of both the cost and the uncertainty around being able to arrange for the funding or afford the funding. And with your comment about what's going on at an institution like Valley Medical Center, that could be part of that, right? It's other hospital systems are facing that. But I'm also curious about impacts for rural communities related to that kind of capital investment and where they're looking at different models to manage the patient. To your point, most of the care might be getting delivered by a physician or a clinic in that local community, but some of it is now going to, whether it's by design or not, be referred out, and how that coordination maybe poses challenges or opportunities moving forward for those rural communities. Any immediate thoughts to that? Okay. Well, then let me spin that a different way. The question, from a rural community aspect, are any of the things that we're talking about lessened or greater in rural communities, the concerns that they would have, being able to access and afford care, or is it kind of agnostic to the size of the community? I see thumbs going up saying it's going to be increased in those rural communities. So I would think that some of the virtual, more innovative solutions that were just mentioned would be maybe more accessible, make more care available in a rural community. But I'm curious about the access that folks have to, internet connections and the technology to support that. Anything that any of you are seeing in that area? Dr.
I'm happy to. So I happen to live in Spokane. Spokane's a city. We have an amazing airport. If anybody's flown out of that airport, you can park right next to it, hop over and right through the terminal. But we serve a huge catchment area, right? So I have patients driving hours to come see me in Spokane. And to your point, exactly on that trade-off. I think, we know that a lot of our rural communities have historically really been helped by Medicaid. Medicaid has been super, super important to helping the health and the wellness of that community for so many reasons. And as that goes away, we double that with rural communities often have a higher chronic disease or poverty. And so that's why you saw my thumbs up. Like, no, this I think is a really, really huge call out for our rural communities and the challenges they faced, tripled down by the fact that a lot of doctors aren't moving to rural communities. They're coming out of school and the kids are looking to stay in metropolitan areas. And so just like you said, I think you said it better than I am. Like, how do you do that trade-off between I had to get gas money to drive round trip, 6 hours or whatnot to see somebody versus the virtual services that may or may not be as I guess maybe not have the appetite sometimes in the community for those services. Like, can I trust this? Am I really getting the full experience? Did a doctor really listen to my heart or check on some of the stuff? Did I get the care I need? So perception being one, but also Wi-Fi being a real issue that I see in my patients. So patients driving from OMAC, down south all over. And I see this as a great concern. Yes, virtual is a solution, but it doesn't work for all the cases. Sometimes I need to get my hands on somebody to really be able to give that care.
Michelle?
Sure. So I can add a couple of things, and obviously, once again, from a retiree perspective specifically, but from a retiree perspective, virtual obviously comes with a little bit of, so some retirees are great of getting on the internet and can access the virtual cares, et cetera, but others, it's not comfortable for them, right? Or they want to, that's not something they want to do, in all fairness. They want to be in front of their physician. And so we do absolutely invest in virtual care, and we have been, and really working through that. And especially from a mental health perspective, as you were talking earlier, mental health access virtually has increased significantly. And it's also interesting because the early generations now are very comfortable with mental health, but the retiree generation did not grow up comfortable with talking about mental health. So having that virtual access, we've seen a huge increase in usage on that basis because nobody knows they're doing it, right? So it's very private. So it's a virtual care perspective. So that has definitely helped. And it also helps in those rural communities because mental health care is really challenging. When you get into the rural communities, it's challenging everywhere, but it's really challenging in rural. I would say, once again, house calls from a retiree population are so critical because when we do those house calls, we're not just focused on delivering the care that we're coming to for like a visit. It's really about analyzing, do they have access to the web? Do they have internet connections? Do they have a safe environment that they're living in? Do they have healthy foods in the home? Do they have their medications labeled properly and are they taking them appropriately? Or do they have 3 bottles of the same medication that they're filling but not taking? Those are the types of things that we analyze in those visits. Those house calls are usually an hour and a half. When you go to provider care, they can't spend an hour and a half with each patient, but they're usually like an hour and a half because we're looking through all of that, asking questions, doing some tests while we can, and also then referring them to either community resources or elsewhere if necessary. But that is a really critical part of the rural care, is being able to continue to have programs like that, because we also, on our retiree benefits, we do have transportation programs. So if somebody doesn't have the ability to get to where they need to go to, we do provide rides for medical care, things like that. So there are benefits that are included out there, but not everyone knows that those exist. So it's also being able to get in front of those people, their caregivers, their family members, to ensure that they understand the full access to care that they do have.
Tom, you have a question?
Yeah. I have friends that live in Chewelah, Colville, Kettle Falls. So one of the things just in conversations with them that I'm familiar with is the kind of the diminishment of in-person services in those more rural communities and having to drive to Spokane. And that is an issue for many people who are aging. And the other half of that is that sometimes you really do need the in-person contact because, and I'll give an example of myself. Without knowing it, I tried to destroy my kidneys a couple of years ago. And I did that by taking a leave. And I was also, because of something else, I was taking some antibiotics. And so the combination of the antibiotics and the leave put my kidneys in crisis. There was an ingredient in the antibiotics called Bactrim, which in conjunction with leave was not a good thing. And none of that, if I would have been just doing that through virtual, that never would have been found out. I happened to go into urgent care and asked them something really unrelated to that. They took one look at me and they said, we think we're going to do a blood test. And then that's when they found out my kidneys were like at a 4 something, and which was not good, and put me in the hospital. So I guess my question is, how do you balance, particularly in rural communities, and even smaller than like Kettle Falls, how do you balance the diminishment of services in person, because like you said, a lot of doctors do not want to go to small communities, and with the needs of in-person care.
First of all, I'll tell you, your story's making me a little nervous about the kidneys. The kidney story. A little worrisome. Creatinine of 4, not good. I agree. And I agree with the in-person, the recognition that in-person medical care is never going to be replaced by a virtual solution. And I would include in that an additional caution with this push towards AI type solutions. Just on that note, I've played around with some of the AI medical bots just for fun, Claude and some of the others. And it has this sneaky way of telling you exactly what is the right answer with little details that are completely wrong. So what you need when you're taking a leave is to have Bactrim. You should have that. And it's said with such authority that you kind of go, oh, that must be right. And it's exactly the wrong answer. So I don't think the right answer is to push toward virtual solutions. As such, a recognition that in-person care is necessary needs to stay as a standard above all of it. David brought up the fact that Medicaid is how our rural communities have really accessed a lot of our healthcare. It's billions of dollars. I think something like $6.3 billion is at risk just from the latest rounds of cuts to Medicaid. So to the degree that we can advocate for Medicaid, we should be, I think. And on that note, I don't know how much this group intersects with medical training programs, but when we say it's not inaccurate to say that fewer doctors want to live in a rural environment compared to a city environment, but it turns out that in particular, family medicine training programs tend to place themselves in rural environments. You mentioned Colville. There's one in Colville. There's one down in actually across the state. We have one out in Elma, for example, and down in Chehalis. And there's an emphasis within primary care, within family medicine training, on rural treatment and rural care. University of Washington tries to spearhead some of that. So to the degree we are able as a group, or you are able as a group, to intersect with training programs that emphasize rural care, on-site actual physical rural medical care, that is a very good initiative to support. And it is still present, it's still there, it's a huge ethic in primary care training, and it should be supported and magnified.
I appreciate the comments and appreciate the question, Tom. I would also call out, a couple of years ago, at the opening of the board meetings, we were kind of highlighting different communities across the state and how the challenges, not just in health insurance and cost of care, but in accessing, whether it was, you were facing a food desert, whether it was you had to get over a mountain pass to get to a primary care physician. And in the winter, that just couldn't happen other than maybe by, fixed wing aircraft, and the cost of having to do that or buy the insurance in case you needed that. Those are very different needs, right? And challenges that folks face. And we've got to be sensitive to that, to the conversation we're having here, I think. Part of it being, if I have a choice between virtual care and no care, that seems pretty straightforward of what I would choose personally, right? But finding that balance, though, with, I think, the underscoring that I'll share a quick anecdote. My sister is a physician, and she used to tell me that one of the things she was told routinely in medical school was 70% of what you need to know, you're not going to take from hearing the patient. You're not going to learn it from lab tests. You're going to learn it from laying eyes on the patient and seeing how they appear and interact with you, right, during the face-to-face. So I in no way would minimize that, the importance of that, but finding a way that we can seek a balance in these rural communities, I think, as Dr. Ankeny was calling out, and find the right level of physician attention and representation. That's a challenge that we're going to be facing, and we as a board, I think, will be working on, or you as a board will be working on. Dr. Ankeny.
I just thought of something I'd like to add to that. Sorry, Harry.
Okay.
There is one of the things that makes virtual care so powerful, however, is something Kaiser Permanente spends a lot of time focusing on right care, right place, right time. Because a lot of times a non-medical person is going to try to access care in a way or a fashion that would be inappropriate for what is actually needed. And that's totally understandable. Nobody can be blamed for that. They're not a medical professional. And so if you do have, if a licensed provider has access through a virtual environment, they're able also to help guide a person to say, you know what, actually, I think you need to get in your car. I need to see you. Can you please get into Spokane? But we don't always have to say that. There are a number of times where people think they need to be seen or think they need to go to an urgent care or especially like an emergency room, when in fact, if they could just have a conversation over Skype or even on the phone, they can be reassured. Actually, in this case, I think I got you. I think I'm okay because I'm trained to see this stuff. I don't always have to have eyes on you. There's times when I do and times when I don't. So just an additional thought there.
Can I jump in, John? I wanted to comment about the younger population. I think the numbers I heard of the visits went from like 1.6 to 2.4 or something. Isn't a lot of that the underlying reason that emphasis is because it has access to or more comfortable with online visits? I mean, I don't know how much of that increase is related, comes right around, well, I can just go online at work. Get on. So my availability is, I don't have to come in 2 o'clock next, week, or I can take a virtual one. So that's just an observation or a comment. Am I onto something here?
You're right on. So I was mentioning just like in-person visits, we do an additional 3 million secure messages every year for a patient population of about 400,000. So yeah, there are a much more frequent like, hey, what about this? Hey, what about this? So you're right on and said it perfect. And again, I see positives in that, right? If I can quickly with a message, like you were talking about, help triage or help guide, your story was tough to hear, Tom, because that's happened I've seen that in my practice when you look at NSAIDs and Bactrim
And I would add that because I have friends in that area, I travel across the state frequently, and when I drive through places like Odessa or Dayton or Ridgefield and those small communities, it must be a real challenge for them to be able to see somebody in line, and that's in person, and then you get more remote, like Republic and Curlew. I've gone through all of those places, and I think about that, and I think, gosh, what do they do for medical services if they don't have somebody that they can see? So it's and I think it's going to be because of the challenges that you have stated. It's going to continue to be an ongoing problem, and maybe exacerbated until this funding thing gets figured out a little better.
And I'll just add on to that really quickly, Tom. Glad that you got the care that you needed and glad you're here with us today as a result of that. So
Me too.
yeah. Sharon.
Thank you so much. Thank you for your presentations. The one thing that really did strike me was your indicator of the importance of preventive care. And I think that should be emphasized much more, especially with younger adults. I'm particularly concerned about the higher rates of diabetes with younger people, type 2 diabetes. That should not even be the case. And they're invested in very sugary beverages, what have you, the carbs and what have you. I don't know if there's something that we can do in terms of communicating the importance of the healthy eating, physical activity, what have you. Younger folks are very facile, you're right. As a faculty at UW, I'm familiar with their engagement in social media. I also recognize that very short attention span, so the work really needs to be very precise and concise in the delivery of that messaging. But we must do better with our messaging around prevention for youth and perhaps be much more creative in how that's delivered to get them to understand, because some of these things that we're seeing now, we should not be seeing. I should not be seeing diabetes or hearing about diabetes type 2. The other thing that you mentioned, which really struck me, was the community-based solutions. There is an opportunity there with community-based work and getting the community involved in their health and wellness and not feeling that they're the recipient of these awful conditions that they're absorbing, chronic diseases, whatever, knowing that they have solutions in their communities, whether it's advocacy or other ways. And so I don't know how that works in terms of engaging them more in their health and wellness and knowing that it's not just about when something happens, you run to the physician, but you can do something early to prevent that from happening. And so that is my concern around the work that we do with our youth, using social media very effectively and creatively, because we can, and they will listen if we do it creatively, and also our engagement with our communities to be part of their health and wellness and not being the recipient of what happens to them. Thank you.
Great comments. Thank you for sharing. So shifting a little bit then, as we opened with changes in policy and guidelines, or where there might be differences in guidelines between a state and the federal guidelines that are coming out, I want to focus on, as an example, vaccinations, because that's one that we hear questions about. Is my vaccine going to be covered? Do I need to get this? Any thoughts about where there are discrepancies between the state level guidelines and the federal, and more importantly, perhaps in this context, for the state of Washington, as we have some of this, the Western States Alliance that's working to seek evidence-based guidelines for care, vaccinations being the primary one right now, no pun intended. Any thoughts about how that effort happens, and most importantly, where the guidelines, what guidelines are being used at the local level right now to administer coverage and availability to vaccines? Dr. Ward.
I'm a family doc, so vaccines are close to my heart. Obviously, we're working to understand, the upcoming implications and making sure that we're, doing whatever is permissible by law. But at Kaiser Permanente, we have not changed our vaccine recommendations at this time. We are, big fans of looking at all of the science that's out there, and there are a lot of groups that look at all the studies and the evidence. And so, whether that's the AMA or the American Medical Association or the American Academy of Pediatrics or other groups that are really looking at the data and making sure we have a full picture to that, the West Coast Alliance, ways that we can really look at vaccines and the health implications to our communities that we serve. I would also highlight that this concept of shared decision-making has always been part of my kind of calling as a physician. And so from the time I started in 2004, I took this oath, and it's like, hey, wait a second. I want to build a trusted relationship with my patients. I want to get to know them, and every patient should and can have concerns about whether it's a medication that they're being offered, or a surgery that they're being recommended, or a vaccine that they're being recommended. And I want my patients to bring me those concerns in an open way. I want to treat that with respect and hear the concerns and talk through how we can come to a decision that patient's comfortable with. So big fan of shared. That's always been there. It's always been part of my practice. That's not new. I'm a father. I have an 11-year-old and a 13-year-old. They got all their vaccines on schedule. I'm very happy about that. Happy to live in a state where that's accessible to us. And on a personal note, 11 is a big most of the last bunch for kids. And we always celebrated going out to ice cream, which should cut back on the sugar. That's a good time. A little moderation, right? Just a little. So bottom line is big fan of vaccines and want to partner with my patients on shared decision-making, particularly during a time like this to help them answer these critical questions. I am seeing an uptick in critical questions. It's making a little bit of a tougher road to climb right now to those conversations, and up for the challenge, and hoping that we can work together with the West Coast Alliance to continue to take care of Washington.
Just a point of maybe a point of reassurance there. Dissonance between recommending bodies plays out a little more harshly in the media than it does in the scientific world. It's not uncommon for one group or another that is highly respected, that we all rely on for advice, to make recommendations or for those recommendations to shift for a while. The reality is that the data on vaccine safety and vaccine efficacy hasn't changed recently. Just some recommendations have. Kaiser Permanente then looked at the other organizing bodies that we also rely on, because they don't really go to just one single source ever, and kind of never did. So we respect the change. It's okay that there's been some changed recommendations or a different way to look at the data that we already have. That's okay with us. We're just sticking with the broader consensus majority of recommendations at the moment, and we're comfortable with that, and that's okay. So as scientists, we look at it and go, okay, well, let's argue about that. That's cool, because that's what we do. We look at data and we argue about it, right? Trying to come to the truth. And as it is, David and I both, we go to our patients and say, let's make a decision together about this. Here's what the consensus recommendation shows at the moment. We're going with that. That's what our policy is at the moment. We're not changing our policy, but we can talk about that and get you to a place where you're comfortable as well.
Like you mentioned, that the way this plays out in the media is a little bit different from how it plays out in the office, and that creates a lot of confusion. I'm a family doctor, by the way, too. Add myself to that list, though. Also believe in vaccines strongly. So one bit of assurance about coverage. When those vaccine recommendations move to shared decision-making recommendations, shared decision-making recommendations for preventive services still have to be covered as preventive services. So no copay, no cost sharing. They're still obligated to be completely paid for patients. We have found that there is confusion about what is paid for. And so we've had some complaints from patients. Well, I don't want to say complaint, but let us know, like, we went to go get our vaccines, and our provider said, I don't know if these are covered for you today. And then that becomes a part of the dialogue, which really shouldn't be a part of this dialogue about prevention. So we're doing, we have an outreach campaign to our providers to hopefully clear that up. But I think that's just something we need to be on the lookout for, and also share that word. They're still covered.
Thank you. And so one of the things that I take away from that is that, this is one of the hopeful moments, right? Is that even though there might be a challenging conversation from a shared decision-making perspective, that it's a point of contact, right? And it starts to build that sense of, trusted expert. This is the person I can go to give me the pros and the cons, right? And understand the data so that I don't have to necessarily go dig through it personally. That's what I love doing, right? I'm a numbers guy and a data guy. But that's not true for everybody. And from, we've heard comments here about it's a time constraint challenge, right? So I think building that relationship is a potential boon that comes out of that in the current environment. So not to editorialize, but I was just doing so.
John, I was just going to add in the past couple of weeks, we've been talking here at HCA about more central communications that we can build to help people navigate the confusion that is inherent with vaccines these days. And we've been thinking about extra communication campaigns that we can do, especially around certain seasonal vaccinations in the fall, as we are getting more into open enrollment, having more centralized resources to cover to describe what all is covered across the plans, in conjunction with the outreach campaigns that individual plans might be doing. So just wanted to highlight that. In fact, we have at least a high-level conversation or piece in our upcoming February newsletter as a first foray into that about general vaccine information. So we see this as an area that the agency can lean into on a communication standpoint. And once again, I have to say, apparently celebrating birthdays in a medical provider's home, very different. We did not celebrate vaccines on my birthday. So just saying, just really appreciating the difference there this time.
Well, Dave, if you get a travel vaccine anytime in the near future, you'll get a different birthday present this year in response to that, since we know you've had a birthday. So again, shifting gears a little bit, you see a lot of coverage, or at least I've seen a lot of coverage recently about gaps in coverage, gaps in care, health insurance coverage, and the types of coverage when you transition between whether it's Medicaid, exchange, commercial, Even at the point when you're transitioning, it's more managed to move from a commercial employer-based coverage to traditional Medicare or Medicare Advantage. But understanding what those changes in the coverages you have are, the network requirements, the benefits, can create its own set of challenges. But focusing for a moment on any of those gaps that occur, particularly, we see it, it's estimated about 1 million people a year transition between Medicaid and exchange coverage. And the gaps are thought to be longer in that kind of a movement. Anything that you all are seeing or thinking about that relates to what happens when we have these extended gaps in coverage and the delay of seeking care, maybe not finding things as early, or what other unseen kinds of things we might not immediately think about in those gaps? Any thoughts?
There's no question that changing healthcare plans creates gaps that tail out and show up. They show up downstream as outcomes, poorer outcomes. We're sensitive to that. Any doctor is sensitive to that. We and I think one mitigating strategy for that is could be on a policy level, which is some program or a system that just automatically enrolls somebody who, if they are pushed out of Medicaid for whatever reason, they no longer qualify, if they're just automatically put into the exchange. We'd love to see something like that, so that they're automatically put into an environment immediately that's going to hopefully put them into another medical system more quickly. And I think sensitivity, just as you brought up, is really valuable. Just the sensitivity to the fact that changing a healthcare payer is always creates disruption. One thing that we do that I've seen that has happened for us is at the beginning of the year, which is when new people come rolling in, we spend more time with our new patients. We're given on our daily templates, we're given more time with new patients. There's a sensitivity, frankly, to just who is this new patient, where they're from, how much have we missed, how long have you been out of the system? And I think that sensitivity is really valuable, because a lot of times just getting them back up to speed is what's necessary. They don't have to come back very much after that sometimes. But in the early going, recognizing it is a high risk environment, and the less we can have it happen in general, the better.
And just a few things to think about in terms of those transitions. Like, we know transitions are where the errors happen. That's normally more of a hospital idea, but it's just true. It's where medications may not get refilled. Some history or records may not get to the new provider. It might take 7 months to get in with a new provider. So the access plays in there too. So I think one of the ways from a health plan perspective that we can help, somebody gets onto a new plan, that plan might not cover the same drugs. Like, you might be on an important biologic that you have to switch over to a generic or something, or sorry, a biosimilar. Or you might not have access to the same specialists. One way that health plans can pitch in is by having something of a grace period. Like, for 60 or 90 days, you can maintain your benefits from your prior health plan to help bridge that gap. Yeah.
John, can I jump in here? I love my chart. I think it's wonderful. And what I've noticed in the last year or so, I did change networks. I had access to Department of Defense care, and I had to go to someplace else. But what I found is that whenever I see my physician, they know so much about me that my physicians in earlier years didn't. They're so much better prepared to see me, and I find it reassuring, especially as I'm aging. And I have to think a lot of it has to do with my chart, because they can see, my past procedures. And so I want to congratulate the medical community, and advocate for my chart. I just think it's great.
And as with most things, as I often heard from my parents, there are pros and cons, right? I agree with you. I like being able to have the interaction with the office without having to necessarily be face-to-face every time via my chart to get minor adjustments or follow-ups. or questions answered. The challenge obviously is I'm thinking of a commercial that I've seen in the last year where it's called out by the physician, actor portraying a physician in the commercial, that there's someone in the room with that physician and the patient whose sole job is to capture the MyChart entries. That allows the physician to focus on what the patient is saying and interacting with the patient. There's some, for me, cognitive dissonance in that, right? But it's a challenge, I would say, for some practices, particularly as they move first to an Epic or a MyChart, to be able to document that and still pay attention to the patient. And there's a transition, like we're talking about here, right, for both the clinician and the patients. But in general, I would say that level of background knowledge and history, I would think we'd have pretty strong support from the clinicians in the room. Yeah, Dr. Ward.
Another little thing of hope on that. If we were having a different conversation over a cup of coffee or tea, I have a lot of concerns about AI. But I'm going to talk about a good example of AI. Right now, we're using for all our clinicians a thing called a bridge. And so when you go into the exam room, an AI portfolio, we get consent from each patient, of course, to make sure they're comfortable with that. But it will act as a virtual scribe. And so before, just to, here's my patient and here's my computer. And I'm trying to do this, 3 thing with this giant. I saw a great cartoon with there's this elephant in the room that's the computer and the patient and doctor squished off to the side, because they're spending time typing. That has been absolutely revolutionary because now I'm asking the patient, is it okay if I use this AI scribe? I set it there and we talk. And we can make eye contact and I can do the examination and it's pretty accurate. I let my patients read it. Hey, did this accurately kind of catch what we said? And it's surprising. We talk about how the Seahawks are going to the Super Bowl. It scrubs that out and then it just keeps to the medical stuff. So that's just a way of hope. And that's as bad as it's going to be if it has the capability to start saying, hey, did you notice this x-ray was done 2 weeks ago or 2 years? Sorry, 10 years ago, anything, 2 weeks, 2 years, 10 years at another healthcare system, and this hasn't been followed up on, those capabilities, that's some hope to kind of streamline this deluge of information that both the patient and the clinician are trying to manage to really focus on what's important. So I know there's risks and there's downsides, but that's kind of an exciting thing that my world has changed in the last year as a physician because of that one product.
To add to that, there's been a commercial barrier among all these called them EMRs, electronic medical records, especially in the early going. And it was like, if you use ours, that's our data. It's actually not yours and it's not the patient's, it's our data. We're not sharing it with anybody else. And at the federal level, this has been increasingly challenged. It's fair. They want to let companies compete and be out there in the marketplace. But what has been recognized and is increasingly more clear is that medical data has to be shared between different EMRs. I need to be able to get in using my Epic from his Centrum or whatever, or these different Alta was something we used in the military. And I need to be able to see what happened in Alta. And it used to be that first of all, there was nothing. They were just siloed. And then in years past, it was like a PDF that you could go look at. Like you go and click on this extra chart and it's just papers of scanned papers, totally worthless in a clinical environment. And lately that has been improving. And a lot of that is from federal mandate to require that that data does talk to each other, even if you're using a different system.
I respect the right to privacy and all of that, like everybody else does. And, who's going to, what third grader is going to hack into it and get it, put it all out in the world. But, to have something good sometimes takes some risk. And so I just like the direction it's heading, that my current doctor can see something that happened a couple of years ago that might, have implication for what I'm going through today without me having to try to say, well, go through the history. They can see the history. Thanks again.
Yeah, just jump in.
Yeah,
Go ahead.
This is going to be really quick. I was going to move on that, the EMR and the EHR, and how that looks for you guys. Because if you're talking about transitioning from one coverage to another, my understanding of the electronic medical records is that in terms of the patient's information, it should be seamless movement, fluid movement from seemingly. So my question to really the three of you is the burden that you're talking about, the challenges that's contributing to the gaps. Is it patient transmission of information? Is it something else? Is it payer at the payer level? What is the real issue? Because I think that that's something that, I'm in a higher ed, that we can do more research on to figure out how the system is working and how we can improve the system. I know that it's burdensome for some people. They don't love it. Some people really don't love it and they want to be rid of it. But I know it has strong potential. So I really do want to hear what is the issue that's causing those gaps in services as a result of trade. Like, what are the real issues that are causing those gaps in care?
I think moving right back to what you were saying, Jeffrey, about sort of the interoperability between it's the health information exchanges, is you can have this wonderful system that works great, like for you, Harry, where they're looking up your history, they know your care gaps, no matter which provider you see, which specialist in that particular organization. And if somebody is on a different EMR at the new setting, none of that flows in. Like at this point, it's not, the data is not in the same format. It might be a different EMR altogether. And so it can't be brought in to then utilize all the same things in that EMR that were circulating, surfacing care gaps, et cetera. And so in those cases, you're still receiving, you're asking for the records from the patient or the provider's office. And it's still like, now we have this big PDF. And right now those systems aren't good at necessarily parsing those PDFs out into all those little spaces they would go, the data fields they would go in that prior EMR. Maybe there's a hope for AI, but I would say the interoperability between the health exchanges and the EMRs would be the biggest issue. Yeah.
So I have a question. It was not what I was going to originally press that green button for, but I do, based on what Sharon said. So if I'm understanding this correctly, I just signed up with a new doctor in August, and it's multi-care. Now, if I wanted to, and I'm really impressed because they use my chart, and I'm really astonished because when I go see my new doctor, he doesn't write anything down. He doesn't, no computer, nothing. It's just, he talks to you. And then I get a notification that I can view the summary on my chart, and I look and he's got everything. And I'm just like, how in the heck does he do that? Well, now I know. But anyway.
Hopefully you got your consent.
Forgot to ask that. But anyway, so if I were to say I wanted to switch from multi-care to Kaiser, and if I'm understanding her question is, there might be a difficulty in that information about me that's in my chart going to you guys. Is that what is the issue?
There's some variability, and I just want to acknowledge it's gotten a lot better. I started my career in academia, and boy, it was like faxes coming in, and it has gotten a world better. And so in your example, I'm really fortunate to work for Kaiser Permanente from a data standpoint, because I can see specialist notes, labs, it's all integrated. And if I had a patient from multi-care, I can click on a button, go in and see all those multi-care notes too. So that's the kind of the hope. This is getting a lot better. And I agree with my colleague. It just, depending on the interface, it's going to be a level clunkier. So, when I have my patient, I set up your problem list, right? So, fake patient, you got diabetes, what's worked, what hasn't, here's the medications. It's organized so my patient and I can quickly understand what that flow is. I've just got to work on some new things. That's what Jeff talked about. When I get a new patient, we're setting that up at that first visit. I'm saying, welcome in. Okay, I can see multi-care was managing your diabetes. Let's put that in our problem list. But it does require more effort. And that's probably one of the easier examples. I don't know multi-care, but I think they're on Epic too. When you start getting different levels of difficulty, sometimes it's just a fax, like Dr. Ankeny said, it's in there. I can read through it, take some time versus some of these. So it's getting a lot better. There's still some clunkiness.
And would that challenge be, for example, if I was with United Healthcare and I wanted to switch to uniform, would that be the same challenge that you'd have?
I don't know if I know all the systems down for me, so maybe someone else can, but it depending on the degrees of separation, that's where those things come in.
Okay.
Yeah, I would just say, to answer that question, Tom, it's something like depending on which provider, like in some cases, if you're switching from one to the other, you're still staying with the same provider system. So your chart wouldn't be impacted at all potentially. But also going back to kind of just transitions in general, we do have, I know there was transition of care was mentioned as part of that. Every health plan does have a transition of care model that works with that patient to try to get them through that first 90 days. If they do switch from one health insurer to another, it's not always the easiest communication process. So that we try to spend a lot of time in open enrollment and communicating with new members around that so that you can get transition of care and you can have your pharmacy filled for a certain period of time, or you can have your, visits, prior authorizations transferred for a period of time, things like that. But we recognize that there's still a lot of room for improvement in all of those processes. And we all are trying to kind of work through that continually.
A little self-advocacy coaching or recommendation for you all. It's valuable to say as a patient, if you are in a new system, to everybody you talk to as you're setting up your appointment or as you're making your appointment, I'm a new patient, I'm new to this system. Can you please make sure that the provider knows, that the care team around me knows that I'm new, and I'm going to want some time to review my chart and make sure that you know what happened in my past. How easily can you access my chart? Those are good questions to ask. It helps focus the meeting when you're in there with the doctor, and even gets it kind of set up beforehand. At Kaiser, a lot of times, every time they'll say it's a new patient. So, be aware, be advised. But especially when you're talking through your membership as well, let them know if you're a new patient, if you've moved from one system to another, you're in a somewhat high risk situation, and it's okay to make that clear to your provider. And let's go stepwise through my medical chart so you're up to speed on where I've been.
Agree with what you're saying, because I think a lot of new patients, they do rely on the technology. They feel that the marketing has been so effective that patients do feel that information is going to be automatically transferred and that they don't need to be engaged as much, right? And I think you're absolutely right to let them know that they still need to be kind of an active participant in all of that and not expect that the technology will take care of it for them. So I think you're absolutely right about engaging the parent.
You're right, Sharon. And that's why I love what David is talking about. Like, when I'm done with this, hey, you want to read this note? Tell me how well I did. Really good input just coming back from the patient. It's kind of new in the eras of medicine.
I never want to end the relationship with my patients, but when some of my patients have had to get a new plan for whatever reason, I can also print out for them, some of this information so they can have it too for the next clinician. So that's another self-advocacy thing. If you're switching as much information as you can get, especially that salient problem list. From my perspective, a well-defined problem list helps my patient and the team know, hey, what's going on at a glance almost.
Just a plug for increased interoperability. I want to note that we're talking about my chart. We're talking about one specific product by one company that makes an EMR. And so for this whole system to work, we'd all have to be using the same product. And that doesn't strike me as, I'm not going to comment on that, but not everybody can afford that particular product either. So, I mean, I've worked in a smaller clinic where not everyone has the resources. The resources to necessarily afford that product too. And so I also want this to be a system that is fair for all those providers, regardless of the size of their clinic.
We've had a lot of personal stories today, and I guess I'll share one of mine that I was thinking about with your question, Sharon. And I recognize everything I'm about to say reinforces that I am not the typical or average consumer. So when I moved to the Northwest from Appalachia, Maryland, I had no expectation that any of my medical records would transfer, and I came with a box of manila envelopes of each specialist, a complete printout of my records, and I knew as I was having appointments, I was like, this is totally disorganized, nobody's going to read it, so I put together like a summary of what was there and all these fun things, because I was like, I just got to make this easier for myself. But so fast forward, I was, if I ever thought about changing kind of where I was getting care, I was like, oh, I don't want to do the manila envelope thing again. We sit and we have all the conversations about interoperability. So one of the things I did, which I don't think is typical, is I was looking for a new provider. I asked that question about what is your system, because I wanted to make it easier for me and them to make sure that my data would transfer. And I think, that shouldn't have to be a question, but it can make things a lot different in your transition experience if you can identify which systems are being used where and to help with that data transfer. So that's just, it's something that I was thinking. I was like, I doubt that the average person is going and asking what their EMR was, but I knew enough to ask that question to make things easier for everyone. And so, like I said, there should be a day when that's not a question that would be helpful for people to ask. But interoperability is a really key thing there. So
You're right. Not typical. We love it. That's awesome. Fabulous.
I also like going to the dentist. We knew that made me unusual.
So switching up again a little bit, this has been
John, can I
fantastic.
come back in here?
Yeah,
I don't know if it's an
absolutely.
unrealistic question, but I'm dying to ask this
Fire away.
question. I have a friend, youngster, who's applied to like 30 schools. He wants to be a PA. He wants to be able to do what family physicians do, but not have to go through an extra 4 years or however many it would be. This kid is 3.5, which isn't the greatest, but a heck of a lot better than me, a GPA at University of Washington in bioscience or something like that. And he's having so much difficulty getting into a school to be a PA. So my point is, I don't know how it is with the doctor community, but we've been hearing this shortage of doctors, shortage of nurses, and I think PA is a great place to go, but I just have to wonder, it's so hard for these people to get into the schools. At least that's my perception. Is it real difficult? Is there just not producing enough, or there's just not enough people applying?
The way I'd answer it is absolutely. We love our advanced practice providers, PAs and ARNPs. It's a great solution. My sister's PCP, so to speak, is a PA. She gets great care. So just want to acknowledge we've got great schools in Washington that are training PAs, and I would say we need more. And then the other thing is even on medical training, not to bring it back to MDDO, but residencies are often where people stay, right? And so the whole ecosystem of training absolutely is a big conversation point to this, but we're very, very pro. That is an excellent solution and a way to help in many ways.
Harry, there is it's Sharon, I think you said you're in higher education. There's a lack of access. Again, there's not enough programs. There's not enough teachers. There's not enough seats to train. But
that's what drives me nuts is I see somebody who I think would be wonderful at it and he's smart, but he can't get in.
Well, academia is an act of love. I mean, it's a mission-oriented thing to be a teacher. I'm on faculty at UW. I think you are too. And so we train to the degree that we can, but it's effort. It's a lot of extra time. I love it, but it's also, it is an act of love. It really is. It is not an act of business. It doesn't pay well. It's hard work. And so getting more and more opportunities to grow is a tough challenge. But I would tell your friend, don't give up. I don't know if you got in your first round. It took me 3 to get in. So, and that was back in the old days. So don't give up. He'll probably get there. It's just the persistent ones usually are the ones who get in there.
Sorry. And I don't project very well, so I'm not higher ed. But even in the School of Nursing, enrollment, I mean, we've been pushing in the community to increase enrollment because there's a need in the state. But after COVID, it certainly has been challenging for healthcare professionals and in terms of us even training. And so I'm hoping that we're moving in an upward swing now in terms of enrollment, same with PA, advanced, a registered nurse practitioner, and all the others. But there needs to be, our healthcare professionals took a hit during COVID. I mean, they truly did from the community. And it's been hard to get folks who want to return back. But I don't see that being continually this case. And so continue that work.
So I did have a very unrelated question, not about what we've been talking about. Would it be okay, or do you want to go ahead? You've got something that
You might lead into something that's coming up, so feel free.
Okay, well, this actually dovetails with what Sharon mentioned and what you mentioned about prevention. So the Health and Human Services has come out with a new food pyramid, which supposedly is to address dietary concerns. You mentioned childhood diabetes, and that is a huge problem. And having been a teacher and familiar with school lunches, they're not exactly models of good nutrition, to put it mildly. So you can go down and get a pizza and a cinnamon roll and chocolate milk and maybe a half an apple. And those are the kinds of things that you get in school lunches. So how do you, so if prevention, and it certainly makes sense to get to solutions early before it becomes endemic, and yet that seems to be what we're facing. How do we mitigate those kinds of things? What can we do that would make things better so that we could address childhood diabetes, obesity? I'm trying to think of, well, and actually from a mental health standpoint, bullying, because that's another huge issue that children in schools are facing. So how do you get to that? That seems to be the big challenge.
I just wanted to start by saying, like, my physician heart is dancing with both of you talking about, upstream childhood, habits and preferences and, lifestyle choices early. I really think that's where we as a society should put in massive, massive focus. I think about all of the different pieces out there on diet, whether it's Mediterranean diet or different pieces that, we study and know. The consistent thing is refined sugar is trouble. Refined sugar is trouble. And even there was a massive big study because, you got the physician here. So I'm going to nerd out on this conversation of like, hey, we thought it was cholesterol. And now how big of a does refined sugar play for cardiovascular and heart disease? It may be the number one. We're still trying to figure out and learn. So that's something we know loud and clear. Exercise. Got to be 60 minutes a day for kids, at least. I think that's like floor, table stakes, should be higher. It's one of the biggest things we know to help kids learn, right, is exercise. So exercise, healthy food choices. My kids will eat a salad. They didn't eventually, but it's just try one piece. Just try one piece. Ooh, all of a sudden, oh, they're eating a full salad. So, how do we get those choices for kids and how do we really get information? And that's where I think this environment is the best because we can talk about it from policy, from marketing campaigns. I agree with Sharon. I think kids are getting their information from, I'm not trying to get into politics of it, but like TikTok and social media. Actually, it's YouTube, right? Anyway, I'm trying to keep up with my kids, but they're getting these shorts, right? And we can influence that with good, healthy information.
Reels.
Okay, you're teaching me. I'm like 6'7". What do I have to learn here? So there's a lot. Bottom line is, I think that's why I talked to the beginning about community investment. Those communities, I think Sharon, you were spot on saying the community knows kind of what does that community have access to? What are the equity concerns? What are the cultural preferences and ways to prepare food that really speaks to that community? That's why that engagement with those community programs is also so critical. That'd be my fast answer. I'd love to talk about that topic all day. That's the way we should go.
Okay, so shifting a little bit, there's been a lot of attention recently to at the national level changes in pharmaceutical pricing and how pharmaceuticals are accessed, even for Medicare. And seeing things about direct-to-consumer programs and how that might interact with commercial coverage or Medicare. And drug price negotiations is something we've talked about with the board over the last year and a half or so. So anything happening in that area that any of you would call out for the board members to be aware of or thinking about? Again, challenges or hopes?
Need on this one. I'm just kidding. So, yeah, from Medicare perspective, there have been significant changes on the pharmaceuticals, very clear with the direct to consumer model, but also the specific drugs being negotiated outright, right, by the federal government and what's going to be covered from that perspective. And so far, from Medicare Advantage perspective, we've actually seen it's very net neutral from an actual cost perspective, which is great, right? So what the government was able to negotiate actually turned out to be the rate minus the rebate kind of rate that we were all kind of paying. So it was very consistent and net neutral from our perspective. However, we're going to continue to monitor market dynamics with that. The concerns and the things that we're going to continue to monitor are mainly around, would manufacturers start passing some of what they've lost from some of these drugs to other drugs? Is there going to be other changes that might impact as they're trying to keep up with which drugs the federal government's targeting versus not? And as kind of market dynamics continue to play out. So we're keeping a very close eye on it. But as of right now, we've seen a fairly net neutral. I think the biggest concern we have today is the uncertainty around how GLP-1s moving into Medicare coverage. I know GLP-1s have been a problem in commercial for a very long time, but from a Medicare perspective, they are now newly potentially coming in from a weight loss perspective. And there's a lot of concerns on how that's going to be modeled, what kind of support is being given to these patients, because the biggest concern is just taking a GLP-1 without physician direction and physician monitoring is significantly detrimental for, especially from a muscle capacity loss. You lose weight, but if you're losing mostly muscle, that's a huge problem. And a huge risk for retirees is falls already. The last thing we want to do is reduce muscle mass and cause falls to be a bigger concern. So there's just a lot of things that kind of go into that, but those are the biggest concerns that we have right now.
Wanted to share a health plan concern with Trump RX, which is really more of just a direct-to-consumer concern. And I know direct-to-consumer medications aren't a new idea, but when a member gets their medication at a pharmacy or uses their insurance, that's the key thing. If they use their insurance to get their medication, their health plan knows what they've taken and what they haven't taken. And we can use that information for productive reasons or in productive ways. Like if somebody who has heart disease hasn't been picking up their statin, like we know that, and we can do the outreach and we can help. If somebody who has a history of psychosis isn't taking their antipsychotic, like we may have a flag up to say we need to get a care manager to talk to this person and see what's going on. We have particular quality measures that we hold ourselves up to. Like there's an asthma rescue to controller medication ratio, where if we see that one of our members is using their rescue inhaler a whole lot, but really aren't picking up prescriptions or don't have prescriptions for a controller medication, that really isn't well managed, and we can get out there and work on that and kind of close that gap. So I just want to point out that with direct-to-consumer pharmaceuticals, all of that information is it's in the ether.
It's in the manila envelope, not an EMR.
It's fine that they will.
Go ahead, Tom.
So, medication, prescription drug pricing. So the Biden administration passed the initial law that the CMS would have the ability to negotiate, I believe it was 10 drugs to start with. And those are actually going into effect this year as of January 2026, that those 10 have a negotiated price. Then if I remember correctly, the second year, so it would be for 2027, there will be 15 more drugs that will be added to that list. Eventually, I think it will go to, I believe it was 48 or 53. I can't remember, because I think it was in increments of 15 after that. So where are we? Are they going to continue to do that? The current administration has discussed capping drug prices, apparently with Eli Lilly was one of the companies, and Merck, I think, was the second one, where they get them to agree to caps. But it seems like there's a lot of, well, like, I think I'll use Dave's term from last year, every day is a new day, with drug pricing and how that's going to play out. Do you, all of you, have any knowledge about where the federal government is going? Because I would think that in the long term, all of these things are good if they continue with it. Do you agree?
A little bit. I agree with finding mechanisms for lowering drug costs. I also agree with Dr. Jones here, saying when you move it outside of the health plan, or you if you move it outside of the provider, you end up with siloed medical care, and that's exceedingly dangerous. There's no way for me to know that you can buy Ozempic now from an independent provider online who's decided that you qualify through a virtual visit. Talking about virtual visits, they'll get through to you for sure. Have a conversation in within about 4 minutes, decide you're qualified, and let you buy the drug. And then I don't know anything about that unless they remember to tell me, because there's literally no data anywhere that I can access. That's not even a MyChart issue. That's still trying to get MyChart to talk with other products is within the healthcare system. This is a totally separate system inside a commercial environment. And when it comes to the Biden and the Trump movement, maybe that's going to work, but not unless it is also tied to making sure that those pharmaceuticals are within the same medical record that we're trying to fix in the first place. Because otherwise we're getting even more fragmented, and it's more of a problem.
So, for example, one of the 10 drugs is Eliquis. And so the price for Eliquis has been set now by CMS. So it would be my understanding that now, if I am someone that takes Eliquis, that what I pay is going to be the same no matter whether I'm with Kaiser, whether I'm with Uniform, whether I'm with United Healthcare. That's what I'm going to pay for Eliquis. And so eventually there will be 53 drugs with a negotiated price if things remain as is. And so no matter who I'm with, all 53 of those drugs would have the same price. So wouldn't that in the long run be a benefit to not only the patient, but the physicians as well?
It depends on the price, and it depends on the reporting. So if it is a better price, sure. And if the reporting is also mandatory so that I know about it. But even so, then fine. It does have potential. It's also now we're talking outside of what, I really have much expertise with, but you having better access to better priced medicines, of course, we're 100% behind that. And David and I have talked a lot about some of the strategies that Kaiser is able to use, because we have 12 million members across the country. And so that gives us a lot of buying power. So there's other ways to negotiate drug pricing that is effective. You can speak to some of those if you want, David. They're kind of fun. Just because there's a lot of hope in the angles that can be pursued to find better drug pricing. But to answer your question, Tom, if it is fundamentally cheaper, and I as a doctor am able to see that that's where you're getting it, and that is what you're being treated with, that's a good thing from the medical perspective, sure.
Go ahead, Michelle. Yeah, absolutely.
Just to one of your comments, Tom, like from the cost to you, I think that what needs to be made clear is a drug is the same price to the plan. So the plan will pay the same price for that drug, but every plan makes decisions on kind of deciding what kind of level of that cost is passed to the member. So the member might see different costs still based on copays, or if there's coinsurance involved, et cetera. So it can still be different from the member's perspective, but will always be at or below that total cost, obviously, depending on the plan design.
So Tom, you and I have talked a lot over the years on this kind of question of, like, just because the CMS sets a purchasing price of it doesn't place it on a formulary and what tier it's on and what those cost shares are, just to tie conversations you and I have had over the years with what Michelle was just highlighting. So it could end up being that Eliquis is tier 1 there and tier 2 here, and we still have this plan that has 4 tiers and this plan that has 5 tiers, and tier 1 is $10 here and it's $5 here up to 20%. So the cost share piece is a benefit design feature that is downstream from the purchase negotiated price for the plan.
I know we only have a minute left, so I think rather than going through more of my discussion guide, if there are any questions that the board members have, let's take a moment and try to address them. So any additional questions?
I have a question, kind of directed to United Healthcare. This isn't directed at, I'm asking you, or I guess I'm just making an observation. What drives me crazy is November and December, the constant advertising on TV. Get a Medicare Advantage plan because you're going to get eyeglasses, you're going to get dental, you're going to get the world, a cruise, everything. Which for many people who want to sign up for that, they're not going to get it. And I don't know if there's any way to combat that kind of advertising. It just drives me crazy because I know people who sign up for things that they later regret, because they've already got a good plan and they sign on thinking they're going to get something. And so I don't know how to combat it, but it's just, fortunately we're past that time of the year now. So don't have to listen to that for another couple of months. So I don't know what, kind of feedback you get from your customers or your subscribers that, I thought I was going to get this. And I would see the burden being on United Healthcare significantly.
Yeah, that's very fair. And we hear it regularly. It's very confusing. I have 2 parents in their 80s and they call me regularly because the same issues, right? When we are sitting here dealing with the inundation, not just on the TV, radio, mail, everything of the information, and the information's not clearly defined. So it does mislead people pretty regularly. And we try to put resources out there to be really clear. And from working with groups like Washington PEB that we are constantly dealing with, we have members who drop off their group coverage, which is much better than anything out in the individual market. And and then they have a hard time getting back on because once you make that decision, it is, CMS kind of regulates what you can do and when you can change again. And so we are constantly working on education, which unfortunately gets sometimes lost in the other marketing that they're receiving. So it's a real challenge that we continue to work on and try to provide resources in regards to how do you make sure that message gets out clearly. We partner with people like Dave and his team here specifically to really make sure that we're being really clear in open enrollment meetings and making sure that we're available and we have resources available to those that we serve, because we really, we're honored to be a part of this program. We're honored to help serve the people that served us in the state. And we want to make sure that you guys are getting the best information you can get. But it is absolutely a constant challenge.
Then I'd like to close it up just thanking the board members for your engagement and the questions and being attentive today. And for our panel members, we really appreciate you all being here and giving the different perspectives and insights. I know you invested your time in this today and we really appreciate it. So thank you all.
Okay, we are going to take a little bit of a break. We'll convene back at 10:55. Awesome. Thank you, Dina. All right. So we are now, thank you, John, again for facilitating that discussion. We're now going to go into open enrollment, which just concluded not that long ago. And we're going to have a summary of open enrollment. And with us today is Alyssa Richards from our benefits accounts section manager in the ERB division to provide an overview of that work from 2026 as well.
So good morning.
Tab 4, board members, in your binder. Sorry, tab 4.
Good morning. My name is Alyssa Richards. I'm the benefits account section manager. I'm also joined by Stacy Groftiza. She's our customer service operations manager. So today I'm going to give you an overview of how open enrollment went. So next slide, please. So the two primary units involved in open enrollment activities within the benefits account section are the customer service team and the outreach and training units. The customer service unit is the first line of contact for retirees and continuation coverage members. Staff in our customer service unit perform three primary functions, which is answering a toll-free line or responding to HCA support inquiries, provide in-person lobby services for walk-in members, and review members' retiree or continuation coverage eligibility as they process enrollment forms. Next slide, please. The outreach and training unit provides training and support to agencies and organizations for both PEB and SEB programs, who in turn act as the first line of customer service for their employees. Outreach and training provides training to the benefit administrator staff on these entities regarding program plan options, covered benefits, eligibility, rules, and enrollment processes. When these agencies or organizations have questions or need additional assistance, they contact our outreach and training team through a dedicated phone line or through our online secure portal HCA support. The outreach and training unit also supports the in-person benefits fairs that are across the state. Benefits fairs are scheduled in-person events where an employee or a retiree can learn more about health plans and benefits. The dates, times, and locations are advertised in our October newsletter as well as on our HCA website. Next slide, please. The customer service and outreach and training units work with other HCA divisions on open enrollment activities year-round. Some examples are preparing our systems for open enrollment readiness to include available plans by county, premium amounts, messaging, etc. Last year, we conducted some focus groups with both PEB and SEB benefit administrators, specifically to review our spousal attestation process within the open enrollment wizard, as well as our dependent screens and upload process. We received some great feedback and made some improvements and changes to that open enrollment wizard, those specific screens, and heard great feedback from some benefit administrators, but also got some additional things that we can focus on for next year. So the focus groups were very successful, and we're hoping to look at ways we can incorporate more focus groups throughout this year. The outreach and training unit secures locations and schedules the in-person benefits fairs. We offered a pre-open enrollment training for benefit administrators in October to prepare them for open enrollment. We also continue to work on the virtual benefits fairs. Virtual benefits fairs is an online website created with the same goal in mind as in-person fairs. Some of the features are that members can learn about their benefits from their home. It's available anytime and can be accessed via a computer, tablet, or smartphone. And some carriers provide direct interactive webinars, pre-recorded webinars, and teleconferences to share plan-specific information. So next slide, please. Open enrollment was scheduled this year, October 27th through November 24th. If you recall from last year, we did make a change to open enrollment date. So it's always the last Monday in October through the Monday before the Thanksgiving holiday. So that was a change for the PEB program. We ended open enrollment on time this year at 11:59 p.m. November 24th. We didn't have any downtime in benefits 24/7, no SAW outages, no weather-related events that impacted members being able to make changes. So we were able to close on time this year. We also made the paper forms available online for employees. So they're always available online for retirees, but we also made them available for employees so they could either complete a paper form and turn it into their benefit administrator, or they could go on to Benefits 24/7 and make the change online.
Alyssa, I also want to highlight for the board that this is now the second open enrollment where we had shifted from being in the month of November to the shift of the last Monday of October to the Monday before Thanksgiving. And for the most part, no pun intended, we've weathered that storm. We kind of purposefully transitioned when Thanksgiving was at the end of a month. And for the most part, it seems like most of the population psyche has permeated this. We still get a couple of questions around that, but for the most part, that seems to have fairly seamlessly transitioned. We have had a couple of members who asked when we made that change, and I'm like 2025. We'll keep pushing that and making sure that that's really clear. But for the most part, that has we've transitioned open enrollment kind of permanently to this end of October to right before Thanksgiving pattern.
And the outreach and training team received 1,444 HCA support inquiries from benefit administrators. Compared to last open enrollment, it was at 2,108. So last year was the first year that we were utilizing benefits 24/7. So there were a lot of questions last year during open enrollment. Next slide, please. We continue to use member feedback for our benefits fairs planning this year. We hosted 14 benefits fairs across the state. Locations for these fairs were selected based on member enrollment. We also supported 4 fairs that were hosted by University of Washington. This year, we, as I mentioned, continue to offer the virtual benefits fairs. There were 38,793 visits, specifically by PEB members. Some of the most popular pages were the UMP non-Medicare, Delta Dental, MetLife Vision, and the KPWA non-Medicare and United Healthcare sites. So I'll now pass it over to Stacy, who's going to talk about how open enrollment went within our customer service team.
Good morning, Chair Moran and members of the board. My name is Stacy Groftiza, and I'm the Customer Service Operations Manager. On this slide, I wanted to provide a visual of the phone trends for 2024 and 2025. The top graph represents the number of calls we answered each month in 2024. The number at the top of each month in the graph represents the total number of calls for that month. The number along the black line represents the average wait time to speak to a customer service representative. So for example, excuse me, in the first column for the month of January in 2024, there were 5,684 calls with an average wait time per callers of 7 minutes. We see a similar pattern throughout the year with call volumes and wait times, aside from a few months where there were some differences. For example, during January of 2025, the higher wait times can be attributed to the challenges we faced related to the implementation of the UMP Classic Medicare with Part D PDP for the 2025 plan year, which generated more calls from members inquiring about their coverage. We had a lower wait time average during open enrollment in November of 2025 compared to 2024. We didn't have any significant plan changes for the 2026 plan year, which really resulted in fewer members submitting plan changes, generating fewer calls from members during open enrollment. Overall, we had a slight increase in the average wait time for 2025 at 11.1 compared to 10.4 in 2024. Next slide, please. Similar to the customer service phones, paper documents received has a similar pattern year to year. Knowing this pattern helps plan work and activities to members, to meet the challenging workload demands throughout the year. This graph represents the number of paper documents received each month, comparing 24 and 25. So in 2025, we received less paper forms than in 2024. Subscribers can submit directly into the Benefits 24/7 system instead of using paper forms. So we continue to see more members utilizing our system. During the 2025 open enrollment, we had a significantly less number of changes submitted. And this can be attributed, again, to no changes to the plan offerings or benefit changes. Whereas in 2024, we again introduced that UMP Classic Medicare with Part D plan, which generated a lot of plan changes, which you can see in the 2024 numbers. In 2024, we saw just over 28% of the OE changes were submitted in the Benefits 24/7 system by subscribers. In 2025, we had just over 37% of the OE changes submitted in Benefits 24/7. So there's about a 9% increase in the OE changes submitted in the system rather than paper forms. And I'll show a little bit more detail of the OE data in a later slide. So next slide. This slide represents the number of in-person lobby visits in 2024 and 25 by month. We saw an increase in the January, February, March in 2025. We had more lobby visits during that time due to plan issues that occurred with the implementation of the UMP Classic Medicare Part D and some default challenges that occurred. We then kind of level out and see similar patterns year to year through the mid-year. And then overall, we saw more members in 2025 at 3,945. We recognize that the in-person service is still a very important service that we offer our members. I did also want to mention, we did a pilot project with Department of Retirement Systems this past year in September. Well, it was September 15th through October 31st. Both agencies serve retirees, and we're often asked questions best answered by DRS staff or vice versa. So during the pilot, DRS had a representative available in our lobby to see members who had questions for DRS. And this was a really successful project, which allowed members to work with both agencies at once. It was a great opportunity to improve the customer experience, and we plan to look for more opportunities to partner with DRS as we heard great feedback from members and staff. Next slide.
I also just want to jump in on that kind of DRS HCA collaborations. The governor's office has signed an executive order challenging agencies to really look at co-locating services for the common people that we serve. We had this pilot in the works before that executive order came out, but it's a great example of like that similar thinking. I can't tell you the number of times in the last decade that I've had a retiree ask me a question or show me something and say your agency sent this and it's from DRS, or vice versa. Or they're like, can you tell me anything about this DRS document? I was like, that's actually us, HCA. And so the co-location of being able to provide services is something that I think is really important for us to be considering leading forward, and would be directly in the spirit of the governor's challenge to agencies to think about that type of work and how we serve the Washingtonians better. So I was really glad to see that had a positive effect for folks, and we will look at ways to kind of make that hopefully a more permanent or periodic thing.
Okay, well, on this slide, I included a matrix of the 2023 to 2025 data specific to customer service during open enrollment. The column on the left includes the interactive voice response, which is a self-service option where members can check their enrollment status, request OE packets and retiree guides, as well as see if their forms have been received. The next item is calls to speak to a customer service representative. We saw a slight decrease in the number of calls, but we were able to make an 8% improvement in the total answer rate. The matrix also lists the wait time average, which is the time it takes to reach a representative. Customer service was able to decrease the average wait time in 2025 compared to 2024, going from 39.2 minutes in 2024 to 22.7 minutes in 2025. Next is the callback feature utilization, which allows callers to, it gives them the option to hold their place in line and receive a call back when they're next in line to speak to a representative. Let's see. And then the next is number of lobby visits, open enrollment forms received, benefits 24/7 requests, and the number of HCA support inquiries received. In 2025, we had a significantly less OE changes compared to 2024, but we see that the percentage of members submitting their OE changes in the benefits 24/7 system has increased. In 2025, we were able to process OE changes and mail out the confirmation letters to members prior to the start of the plan year, which hasn't always been the case. So that was a great win for us. I also included the number of fully trained staff available at open enrollment for full customer service duties. In 2025, we had 19 fully trained staff. And so that's my last slide. So I'll send that back over to Alyssa.
One more thing, I just want to reinforce for the board that the metrics that Stacy was going through are generally about the direct account service that our agency does for retirees as well as COBRA members and COBRA from both PEB and SEB. So this isn't generally anything to do with the employee side of the equation. This is mostly retirees and COBRA.
Okay, so now I'm going to go through some information about switching. So on this slide, you can see the net changes for each plan for non-Medicare members. You can see the total enrollment by plan for 2025, which is a snapshot in October just before open enrollment begins. In the next column, you can see the final OE results for each plan effective January 1st, 2026 in that 2026 column. And then the totals in red show an overall decrease in the plan enrollment from 2025 to 2026. And the last column is the percentage change in the plan. Next slide, please. This is actually a new slide that we added this year. So we wanted to provide a roll-up of enrollment by carrier over the last few years. So you can see the total enrollment by carrier in 2023 through 2026 for non-Medicare members. You can also see the change in overall enrollment for each carrier in the last column from 2023 to 2026. So for example, you can see Kaiser Wa has an overall decrease since 2023 of 11,186, while UMP has an overall increase of 23,368. And so again, this is our non-Medicare enrollment.
One of the reasons that I asked Alyssa to have this type of slide in is it's no secret that we know that there's been volatility and a lot of changes in the premiums and members moving with their feet. There's been a lot of discussion from board members about the importance of consumer choice and not wanting to necessarily cut off individual plans, and just thought with the story arc of the last couple of years, it might be interesting to see some of the trend lines and then the macros. One other piece that I think is interesting in this data that I was very curious about is we all know that there were a lot of premium increases in the Kaiser Wa plans between 2023 and 2024, and we saw a significant member changes that happened in that year. And then we also know that last year to 2026, there was another shift in the premium that you might anticipate similar type of losses, but in fact, it looks like there's a lot more stability in the more recent years, and I thought that was instructive or helpful to kind of point out for the board. Also, just wanted to share that if you took this slide and kind of set it side by side with its SEB counterpart slide, you would see similar trends. You would see about 10 to 12,000 overall member growth from 2023 to 2025, and you would see similar orders of magnitude in the shifts from out of the Kaiser system and into the other carriers. So just wanted to share that it's generally, these two populations in these two separate risk pools in these two separate programs, it continues to amaze me. Everyone says when you have a large enough risk pool that it starts to look the same. And these two programs really have a lot of eerie similarities, even though there may be more dependence in one program and average higher age in the other program and more babies in this program. And, all of those upwards and downward pressures are in different directions, and it all kind of normalizes and is really similar at the end of the day, which I continue to find very fascinating about the two programs.
So I have just a quick question. So I'm looking at this 2023 292, 24 98, 302, 302. So do you think that that's 10,000 more? And you said there's a similar trend in the SEB. Is that probably because of COVID and the fact that things were opening up more, and so you were able to hire more? Because it's not necessarily a healthcare authority, but statewide, because this reflects active employees, correct?
It does. It's active employees and non-Medicare retirees.
And non-Medicare. Okay.
Yeah. When we say non-Medicare members, we say that to convey that it's non-Medicare retirees and active employees. not just active employees. You know, in PEB, there's a couple of different factors. You know, we have local governmental entities that contract into the PEB program every year, and we've seen an uptick in the volume, the number of employers. Usually they tend to be smaller employers, maybe 25 covered lives or less, often even less than that. But we have seen each year in the last couple of years, a couple of larger, a couple of hundred employees in an individual entity. So we've seen some natural growth just from the employer group joining the program. You know, on the sub side, they don't have there's the capacity for local other entities in the K-12 system to join in, and no one's actually opted that. The growth there, which also may have some effect here, is in the dependent area. You know, there's so much that's been happening in our health system and a lot of changes in general, and so people may be coming on from or losing coverage in other areas and deciding to come into this area. I do think there was a point where we were seeing some net losses in the oh, never mind. I was about to talk about Medicare. Never mind. I'm going to stop. Does that help, Tom?
Yeah.
Okay. I'll just stop.
Okay. Next slide, please. So now we're going to talk about Medicare. So on this slide, you can see the net changes for each plan for the Medicare retirees. You can see the total enrollment again for 2025, which is the snapshot just before open enrollment in October. And then the 2026 column is the final results for the plan year 2026. And then the totals in red show the overall decrease in the plan enrollment from 2025 to 2026. Next slide, please. And again, we did the carrier roll up on this slide from 2023 to 2026 for retirees. So you can see for Primera, we can see an overall increase in enrollment from 23 to 26 of 4,356. In UMP Classic Medicare, there was an overall decrease from 2023 to 2026 of 8,765.
Similar on this slide, when you think about the shift of the Uniform Medical Plan Classic Medicare to having Part D coverage, you can see how that stabilized the member volume in that. I mean, it couldn't be plainer than day on this slide. X marks that spot, and you can see, you know, a lot more stability in the enrollment at that point.
Next slide, please. On this slide, you can see a view of where subscribers started and where they switched to for plan year 2026. I don't have them all listed here. This is kind of a condensed version of any changes over 150, just so that the visual is readable. So for example, on this slide, you can see 590 subscribers moved from UMP Plus University of Washington to UMP Select. 633 subscribers moved from UMP Select to UMP Classic. 8,471 subscribers enrolled in UMP Plus University of Washington either selected to move or were defaulted into UMP Classic if they didn't make a choice during open enrollment. And then 3,598 subscribers that either changed or were defaulted to UMP Classic from the UMP Puget Sound High Value plan. So next slide, please. And then this, similar to the last slide, but this is specific for those UMP Plus enrollment. So as you know, the plans, the two UMP Plus plans are no longer available effective January 1st, 2026. So this slide is showing where folks started and then where they ended up for 2026. That is the end of my presentation. Are there any questions?
Yes.
Yeah.
Okay, if I can refer you back to slide 11, well, you don't have to go back here. It says that in 2025, there were approximately 27,000 member changes for UMP plus both of those networks, right? So on the most recent chart 16, where it shows the movement, that adds up to like 12 or 13,000. So is one reflecting kids and everybody, all total members, and one's reflecting subscribers or employees? I'm trying to understand, unless I could be totally confused. It happens.
The UMP plus on slide 11 is total members.
Right.
And then on 16, which I don't have all of the totals labeled here. I want to double check. I'm pretty sure it's also all members.
So I'm wondering how we had 27,000,
Mhm.
but only 13,000 moved. So I'm kind of thinking that one, help me out here, is the one on 11 reflecting everybody? You know, I don't know the right term. It's a subscriber, the
Member
employee.
versus subscriber.
Yeah.
So yeah, subscriber being the employee, for
Okay,
example.
so is this one subscribers
Yes,
and the other one is total
members.
members?
Yes.
Got it. Okay, and so that's great. I'm no longer confused about that. Do you know offhand how many you defaulted from one of those plans into the other? That's part A, and part B is, did you get a lot of feedback after you sent out the letters and said, oh, I didn't sign up for this. I didn't know I was moving.
Yeah, I don't have the totals of who was defaulted versus who actually selected
Yeah.
to go into UMP Classic, but I can definitely get that.
Yeah, I'm just curious, how many took.
Made the choice versus.
Yeah, or just said, well, let them do
Let
it, or didn't know, even though they were provided the information,
Mhm.
didn't, just didn't sink in or whatever. And so your staff didn't get a lot of angry callers.
We haven't gotten a lot of angry
Yeah,
callers,
good.
no. Where we would probably see that is when we start getting the appeals related to open enrollment changes. So I can definitely look to see if I have any data around that.
I know you guys do a heck of a job during open enrollment. I really appreciate the volume that you're dealing with. And so congratulations to you.
Thank you.
Tom, did you have a comment or question?
Oh, I'm sorry.
Okay. No worries.
Ryan, I did want to just say for the board, in my tenure with the programs, this was by far easily classified as the smoothest open enrollment that we've had. By all metrics, you saw that the wait time was lower compared to last year, that the document churn that happens during open enrollment was lower than last year. There was not any major technology issue. So it very easily qualified as the smoothest open enrollment. And as we've had our various stakeholder meetings that we have with benefits administrators of both PEB and SEB and labor partners from both PEB and SEB, we've had this conversation about how open enrollment went. And there did seem to be a very common sentiment that there was agreement with my statement, that there were a lot of positive things that were seen. There was an appreciation for the amount of focus groups that were had with benefits administrators and feedback that was clearly taken to heart. There were changes that were done in our open enrollment wizard related to the spousal surcharge and dependents. There was definitely appreciation for those changes, while also suggestions that there are still opportunities to improve them, and we will continue on that effort. And absolutely not saying that we will rest on our laurels and there's not areas for improvement, but by all metrics, things trended in a positive direction from all angles, and really proud of the team for how open enrollment went this particular year. It also reinforces that when we don't have a lot of changes happening in the program, open enrollment runs more smoothly. And I'm just going to drop that breadcrumb and pick that up a little later in the meeting when we're talking about the need to focus on IT infrastructure changes and sequencing some other major policy ideas that are, around for the programs. But just, the smoothest of open enrollment has a lot to do with the team, the staffing levels, and also the amount of change or lack thereof that's happening within the program for OE as well.
Any more questions from the board? Great. Alyssa, Stacy, thank you so much. Appreciate your leadership. All right. Going to move us along. I'm going to invite up Cade and Tanya. Cade from our policy, rules, and compliance section, and Tanya from our financial division. They are going to give you an update of what's currently happening on the Hill. Just a little bit of distance from here during legislative session. So Cade's going to be going through some of the bills under consideration that we as an agency and ERB division are tracking. And Tanya is going to go over the governor's proposed supplemental budget that was dropped this year as well. So Cade, first to you.
Thank you, Chair Moran and members of the board. Good to be with you again.
Tab 5, board members, tab 5.
keeping a little distance from Tanya because last time I was up here, she did threaten to kick me under the table for a comment about enjoying ledge reports because I think they're rather interesting. And it gave us a big opportunity to provide some good work for them. So
Social distancing to a new
Yeah.
level.
you know, you learn, you live and learn.
Someone get Tanya a cane.
Yeah, can't win. All right. So session has started. We're about 3 weeks and we're about a fourth of the way through our legislative session this year. It's a short session as we had the long session last year. So we have a 60-day session this year, which in a lot of ways is great because it's a significant amount shorter than the long session. But a lot of times it's kind of like having a 3-day work week where you have Monday and Tuesday off and no one really respects that it's just a 3-day work week. So they try and cram in everything into a short period of time. So it's a pretty quick session with a lot of things happening in the first part of things as we get moving along in the session. So we'll go to this first slide here, just showing you kind of the work that we've done so far in our division. As you recall, ERB is part of the larger agency's effort on doing bill analyses. We review bills based on the impacts they would have to our division. If we are asked to be the lead for a bill analysis for the agency, we will incorporate the impacts that are noted from other divisions, as well as the impacts that it has to our programs that we manage within the ERB program, which is where we have kind of our split here between our lead bills and our support bills, where we're either asked to be the lead analyst for the agency or support analyst for the agency, given the other programs in the agency that have impacts from legislation as well. Then we'll divide things up, priority into a high or a low priority, which really is an arbitrary standard where what we're doing is saying, is the legislation that we're reviewing, is it going to actually have an impact to our programs, either on a financial level, an administrative level, something that's going to change benefits? Is it going to cause us to have to amend our rules or our policies? And that's just a differentiation we make for the kind of attention that we pay to legislation to see, is this going to have an impact to our program? And then we'll be tracking a little bit more assertively than we would on other pieces of legislation. Thomas, you got your mic on.
Yeah, I just quick clarifying question. So where it says fiscal notes 7 and 18, those numbers from the total numbers up above? So ERB laid 13, 7 of them have fiscal notes, 50 for support, 18 of them fiscal notes.
That's correct.
Okay. Thank you.
Yeah, thank you for the note on the fiscal notes. We've also had, I mean, these are, and just as a reminder, this is as of last week. Things are moving very fast. We've already seen a significant number of increase on the fiscal notes and on the pieces of legislation that we've reviewed. Also, as a way of a note that even though this is just what we've reviewed this session, because we're in the short session, it's still part of the legislative cycle. All the bills that were introduced last year that did not make it through the process of becoming law, those are reintroduced by rule and are also considered active. And now, whether they are moving through session or not is up to the legislature to move those things through different committees. And just as a note, the appendix that I've included in this presentation on the backside includes the pieces of legislation last year that passed, as well as the pieces of legislation that we were tracking and I mentioned to you last year for your note. Some of those have been reintroduced and are starting to move a little bit through the process that I'll speak about, but just giving kind of a high level overview of what we've done. I also just want to take an opportunity with this slide to thank all the analysts that we have in ERB and our fiscal team, Tanya and her team, for all the great work they do in getting things popped out, getting these bill analyses done timely. There's a quick turnaround when pieces of legislation get introduced that the analysts have about 3 days to get that to go through sometimes very complex pieces of legislation and contact carriers and make determinations about what the impacts would be to our programs and write that all up, get it through approval process and get it so that we can advise our agency leadership if we need to have any conversations with legislature or make any comments at public hearings for them. So they've done a really great job this year in getting those things done timely, and it's incredibly good analyses that are being done by our team. So next slide, please. This is our progression of how bills become laws through the different processes here. On the left, you'll see the times, the dates there for the cutoffs for these different committees. As you can see, we are fast approaching the first committee, the policy committee cutoff next week. I think it's next Thursday, which is the first big cutoff of session where nothing, with rare exception, anything else is going to be introduced past that point. So we'll have a pretty good idea of what legislation is still out there and moving as of the 4th. So these are just some of the high priority bills that ERB is the lead on. We're tracking, seeing where they're going through. Just one, you'll note one of the bills has already made it through. That's actually a bill that's been brought back from last session, 1069. So that's been moving through because of the way it was where it had gotten last year. It's now settled back into the opposite chamber of policy for consideration there. So by the time I'll come back to you at the next meeting will be either right at the end of session or session will be over. I'm not quite sure, Dave.
We meet on the last day of session.
So it'll be right at the last cusp of things, assuming that we're not going into any extra innings here. And I'll be able to provide an update. So this will obviously be changing a lot between now and when we come back in March. But just giving you an idea of where we're pretty early in session still, but things are moving rather rapidly. Next slide, please. Just a reminder and a note, last year we did have a couple of pieces of agency request legislation that we put forward. This year, however, we did not have any that we deemed were appropriate to move forward with the current budget situation that the state is facing, as well as just there was nothing that we had urgently that needed to have any sort of corrective fixes done. So we didn't have any legislation from our division that we put forward. But just as a reminder, last year we did have we had Senate Bill 5083, that did pass, and we are currently in the implementation phase of that legislation, working with our carriers and making sure that we are getting this implemented. And then we had Senate Bill 5478, which expanded the benefits offering authority for this board to be synchronous with the benefits offering authority that the SEB board has, and being able to offer specific types of optional benefits like travel insurance or pet insurance, and a whole slate of other pieces of optional insurances that could be provided by this board on an employee paid basis, subject to available funding for doing a procurement to find those benefits. There was no requirement for anything to be procured or any benefits to be offered, but it's really just making the board offerings authority between the PEB board and the SEB board to be congruent with what those types of benefits are.
I'll just add quickly for the board, 5083, some people think of that as the Public Employee Affordability Bill. Other people call it the Reference-Based Pricing Bill. We will have more information about how that implementation is going and present that to the board later in the season. Didn't put that in today's agenda. Some of it may actually be an executive session as we get further. So just highlighting there is much more to come on that. You may have questions, but I ask you not about those today. We'll talk about that. That'll have its own dedicated time later.
All right, we'll move on to current legislation that is currently moving through the process. These aren't in any particular order. As I've kind of put them together, trying to get things on the paper as the very last minute so that Jessica doesn't get too upset at me for having maybe the latest and last possible person to get a presentation in.
You get kicked a lot, Cade.
Sometimes
strategically sitting equidistant from Jessica and Tanya. Dean, why don't you move to the front row?
I should start playing soccer with how much that actually.
Yeah.
So let's start with 2160 and its companion 5083, which our team is the lead analyst on. This has a significant impact on the SEB program as it's expanding. It would expand eligibility for the SEB program by codifying what is currently in rule, referred to as the 2-year look-back rule. This would codify it as a 1-year look-back rule and provide some additional flexibility in the determination of that 1-year looks-back rule between districts. It doesn't have any impact on this program, but it does have it would have a significant impact. And I'll speak I'll say it would, because I'm thinking if it were to pass, it would have these impacts, but these are all subject to them actually passing. So please excuse me. None of these have passed at this point. So if I speak as in the present tense of this, this is what it does. It's what it would do should it pass. So please excuse my phrasing if I'm not perfect on that. But should this pass, it would have a significant impact on the SEB program and expanding eligibility. Tom.
So it's my understanding that if like I was hired to teach for this school year, 25-26, I would be automatically enrolled in the SEB program as a first-year teacher. Isn't that correct?
Maybe, which is a great lawyer answer. It would depend. It would depend if you were being anticipated to work 630 hours in that school year. So if you were hired and your FTE level that you were hired onto was such that the school district's administration anticipated you to work 630 hours, then you would be enrolled in benefits.
So I'm given a FTE 1.0. So I'm assuming as a full-time over 630 hours. Well, then my next question is, so then this second school year, if I'm rehired for the same position for the second year, wouldn't I automatically be enrolled in the SEB? And
Again, so the school district on an annual basis, unlike the PEB program, where once you've been deemed eligible and you're in that position, as it rotates through every year, there's not really the same sort of hiring cycle that there is in the PEB program as in the SEB program, where you do have these kind of distinct school years where every year in the SEB program, there's supposed to be a redetermination of eligibility for the SEB program. And so at the start of the school year, every year, the administration would go through and say, all right, let's see, who are we anticipating to work 630 hours this year? This rule, what's currently in rule, referred to as a 2-year look back rule, and then what would be codified should this legislation pass, would create a 1-year look back rule, which is a rebuttable presumption that's able to be made by the employee to say, look, yes, you're not anticipating me to work 630 hours this year for some reason, but last year I did work 630 hours. I'm in the same type of position that I am going to be in this year. And so I get to rebut your presumption that I'm not going to be anticipated to work 630 hours. That's a lot of tap dancing around it, but it really is a way for employees to say, I did work 630 hours last year, even though you might not have anticipated me to work 630 hours, because there are some of those positions, as you're probably well aware, Tom, that you're not initially anticipated to work 630 hours, but because of needs of absences and needed to be filling in, or whatever that is that occurs over the school year, you end up working 630 hours. That creates a presumption of eligibility that you're doing the same thing you did last year. Last year, you did reach 630 hours. The district might have you at a 0.4 FTE, which wouldn't necessarily put you above an anticipation to work 630 hours. But because of the type of position it is, this would largely be impacting the substitutes, whether that's, substitute bus drivers or substitute teachers, lunch workers, et cetera, like that, where they might have not been anticipated by the district, but the employee can come back and say, well, I have worked 630 hours. Currently, I've worked 630 hours last 2 years. I'm still in a substitute bus driver position. Ergo, I am eligible under the 2-year look back rule. This codifies it, shrinks it down to a 1-year look back rule. So if you had worked 630 hours a year before, and you're in the same type of position that you were in for the subsequent year, that you would have that presumption of eligibility based on this new codification of a rule.
Dave, I don't think your mic's on.
It is.
If this did pass, that is different and could impact retirees. Is right now you cannot, when you're looking at sub eligibility, stack hours. The way the bill is written, the person who substitutes multiple districts could get to count those hours across districts. And districts right now, they don't really have to pay to 4 hours if we system to help them with it, but you would add up all of those hours. Right now, there are many, anecdotally, in this board, public comment about this. There's been conversation around the interaction between Medicare retiree coverage and SEB eligibility. There's knowledge and awareness that there are Medicare retirees who are purposely bifurcating their substitute hours across multiple districts because they do not stack, because they want to avoid 600, so that they don't have to have Medicare coverage, go on the school employer-based coverage, have that churn between Medicare and SEB. But in this future state, if this bill passed as written, all those hours across districts count. Once you hit 630 across the totality of the K-12 system, you benefits eligible. And so that very dynamic where Medicare retirees may be that would be offended by this bill. And once you hit 630 in the system, you're not able to, you'd have to defer your PEB Medicare coverage.
Yeah, there's a consortium for the school districts in Thurston County. I don't think Olympia and North Thurston belong to it anymore, but the rest of them do. So if you sign up through that, if you substitute in Rochester, if you substitute in Tenino, if you substitute in Tumwater, all of those hours accumulate. But what you're saying is currently those are separated, and so it kind of is almost up to you under the current condition to keep track, or?
If you want to not hit 630, you're in the best position to make sure you don't have 630 hours in specific district.
Yeah.
Because you as a substitute declining substitute hours. And you could, because under GRS rules for return to work, you can work, I don't remember the exact threshold, more than 630 hours and not have something happen on your pension. But under SEB eligibility, once you hit 630 single district right now, you become SEB benefits eligible. Under this bill, it would be 630 hours.
Tom, you mentioned something I'm curious, well, I'm probably not appropriate for me to ask, but I'd love to follow up with you about that consortium idea, because that's something that would be against our rules that we have currently, where eligibility is only, there's no stacking between districts. So it's, you work 630 hours in a district in order to gain eligibility. We don't have anything within our rules that allows for stacking. So Carol, if you're listening, if you'll make note of this, and we want to follow up with Tom and just kind of ascertain is if that's happening, that's that's not in line with our rules, and we would need to be addressing that, because that would, again, that's outside of our scope of what our rules would allow. So thank you for bringing that up, and we'll track on that a little bit. All right, moving on. Some of these are maybe a little less exciting on eligibility type things. Nothing else really touches on eligibility. 2546 and 6071, standardizing overpayment recovery requirements. This is reducing the time that carriers have to seek recovery of overpayments to providers, specifically mental health providers. It reduces it down from 24 months down to 6 months. So they only have 6 months to try and claim those overpayments. Then we have companion bills brought back from last session, 1069 and 5044, which is allowing collective bargaining over contributions for certain supplemental retirement benefits. And I know Dave usually has more information on that if he wants to share on the supplemental retiree benefits, 1069.
No, I don't think there's anything that more to add to that. It's something that we're definitely tracking closely, as it could have. It has lots of potential applications, so it's just something that we're monitoring really closely.
The next slide. Oh, Kurt.
Yeah, I would be interested in a little bit more information. Obviously, this is the state collective bargaining law, so something I'm very interested in. I mean, I can read the bill, it limits bargaining to supplemental retirement benefits, not the plans administered by DRS. But can you give me a little bit more about what the intent is here and why it's needed?
Yeah, Kurt, there's especially a lot of this is being driven by DOC employees that are at the Department of Corrections, who have because of the nature of their occupation may tend to leave the workforce or quote separate/retire. I'm using those words loosely and not precisely at the moment, earlier than other parts of the population, and then really challenged. I think many are challenged with those non-Medicare premiums. One of the things that we learn about as people are planning for retirement is that time when you're bridging from exiting the workforce and becoming Medicare eligible, those non-Medicare premiums in the program are really expensive. Doctors celebrate, when they can have their colonoscopy and vaccines with their kids, and retirees celebrate that they turn 65 and their premiums drop on their invoices. It's a really big phenomenon, and I hear about that quite a bit. And so this bill is trying to look at especially address the longevity of corrections workers who are in that non-Medicare space, and potentially opening up options for them to be able to access cheaper health insurance during that period of time. One of the concerns that we've raised is that coverage that they might go to might not actually allow them to be in deferral status, and they wouldn't necessarily be able to return to PEB when they become Medicare eligible. But that's kind of the problem statement, if you will. Is that helpful, Kurt?
Yes, thank you. Appreciate that.
Thank you. Next slide, please. House Bill 2106. This is a legislation requiring carriers to provide substantive notice to healthcare providers and healthcare facilities about significant contract modifications. The operative words there being significant contract modifications. This would require a 90-day notification from health carriers to the different providers that when there's going to be any significant modifications to their contracts. This kind of gets into the issue that we've been seeing the legislature address for a few years now about network changes in mid-plan years where there are contract negotiations and the impacts that it has on members. And this is addressing some of those impacts that exist between kind of in the precursor moments to the members being notified, having those notifications where there's going to be significant things such as modification in their fee schedule or downward movement in their fee schedule, or how they're going to be doing billing, things of that nature, for the providers to have adequate time to prepare a response and position themselves for negotiations. We have House Bill 2242 and 5967, preserving access to preventative services by clarifying state authority and definitions. This would be codification of the work that's being done by the consortium of states between Washington, Oregon, California, and Hawaii regarding vaccines and immunization schedules in response to the federal change of those guidelines. House Bill 2522, it would be advancing oral health equity and protecting access to preventative dental care services, granting dental providers greater ability to seek additional covered visits for patients who needed to have more visits as determined at the kind of the primary dental care point of contact. Next slide, please. 6183 concerning coverage for HIV antiviral drugs and ensuring protecting and increasing accessibility to HIV antiviral drugs. House Bill 2145 and 5981. This is about ensuring that there are safeguards and preservation of pricing for certain drugs that are subject to the 340B federal drug pricing program. And we have House Bill 1566. Addressing and making some changes and modifications to the prior authorization processes that exist, having some additional modifications to the prior legislation regarding prior authorizations. Yes, Tom.
So I'm House Bill 2145, 5981 Senate bill. I'm not very familiar with what's the issue that this legislation is attempting to address.
That's a bit out of my pharmaceutical understanding range. I know that we are tracking it. Our clinical quality and care transformation team is tracking it because of the implications it has across all of our programs that have pharmaceutical implications. I don't know, Tanya might have.
Yeah, so Tom, it's really about the contracting pharmacies and protecting that around, let me back up. So 340B entities get a certain cap on their drug prices. These are things like FQHCs, Ryan White facilities, certain types of hospitals, which then have contracted pharmacies outside of the hospital. This bill is really about that relationship because we as PEB members, if we fill one of our prescriptions at a 340B covered entity or contracted pharmacy, those entities actually purchase the price at a lower price, but then they charge the commercial insurance the same rate that would be under our contracted allowed amounts. You would pay your standard cost sharing as if it was not a 340B price drug, but we are not allowed to collect rebates on those drugs that are purchased through a 340B entity. So our fiscal note is really about, this is status quo, what's happening today, with the acknowledgement that if there were an expansion of contracted pharmacies purchasing under these 340B covered entities, we would lose ability to collect additional rebates on those drugs. So for us, this bill's really kind of status quo unless there was an expansion of additional contracted pharmacies that would mitigate our ability to collect rebates on those drugs filled at those contracted pharmacies.
Thank you.
And then last slide, please. Our last piece of legislation that we're tracking for note here is 2487, and its companion bill regarding taxes imposed on insurers operating within the state. This is being led by our financial services division. It's just we're keeping an eye on that because of the potential, if the definitions were to include health plans, health carriers, we may see some taxes arise out of that. But I don't think currently, is our fiscal notes on that it's.
Yeah, the fiscal notes did come in on this actually today while I was sitting in the back of the room. Like Kate mentioned, they're coming in fast today. This bill is really about kind of just tying up state law with I believe it was a Supreme Court decision back in 2024. Either way, there was this ability for carriers who pay a premium tax to kind of get out of paying certain B&O tax liabilities. And this is just really tying up the state law with that decision and making it really firm in state law on that relationship between when someone pays a premium tax versus when they do not pay premium tax. We do believe that there will be a impact on our fully insured carriers who will have to, pay some of this B&O tax now in the future. As we're currently analyzing the bill, we don't believe the UMP plan will be impacted because we are not subject to premium tax under the way this bill is currently structured. We think that for UMP, there would be no cost, but there might be an impact on our fully insured carrier slightly.
And that's it. As I mentioned, the appendix has bills from last year that passed and that did not pass, that we were keeping a view on keeping an eye on the bills that did not pass in case they do pop their head up again before the 4th. But with that, I'm happy to take any questions. Otherwise, I'll turn the time over to Tanya.
Any questions from the board or any questions from the board online? Okay, seeing none, no hands. Tanya, thanks, Kate.
Thanks, Cade. Good morning, Chair, members of the board. I'm going to give you guys a quick update on what we've seen come through in the governor's proposed budget, which came out in December. So as a reminder, we're in the middle of a biennial budget. So legislature took action last session to enact our biennial budget for the 2 years. So really fiscal years 26 and 27. This is the fiscal year 26 supplemental, which we have the opportunity to submit funding requests known as decision packages for adjustments to things happening within this biennium. First slide is just a reminder of our timeline. During the summer, we look at recommendations that have been brought to us by either the board, some of the board's priorities, public comment, requests from our carriers, things that we want to prioritize as an agency and move forward into a decision package request for the Office of Financial Management for inclusion in the governor's budget. Those are done through the late summer, early fall, and then the governor's proposed budget comes out in December, which is what we'll walk through today. We are anticipating that last day of session will be March 12th. So by the next board meeting, I'll hopefully be able to give you some verbal updates depending on when we see the final conference budget. But we'll update you along the way as we have more information. Most anything that comes out of this supplemental budget will go into effect July 1st with the start of the new fiscal year. Let's walk through a few of the decision packages that the agency did put forward. One thing we really kept in mind this year when submitting decision packages was the current state of the budget. We had a lot of conversations last board season on some of the budget reductions the agency took and kind of where the budget, was. Robin came from the Office of Financial Management. We talked a bit about, the forecast and the overall state of the budget. We kept that in mind when looking at the decision packages we wanted to put forward this year. So the first one that we put forward was the one I bring back to you guys annually, which is our third-party administrator spending authority. Our TPAs are those administrators that we contract with to help administer our self-insured medical and dental plans. So Regents for the uniform medical plan on the medical side, MODA for the pharmacy side, and then Delta Dental on our uniform dental plan. As enrollment changes, we just have to true up with the enrollment in those self-insured plans and the amounts that we need to pay these administrators. What's different this year is you'll see in the dollars it says included, but final amount TBD. And that is because this year I was really aware of the state of the budget and didn't want to be overly conservative in our decision package and just put projections in there. I wanted to wait until we saw the results of the actual open enrollment switching, which we knew with the closure of the PLUS plans could have a shift in our self-insured total enrollment. So the governor's budget did include the line item in the budget acknowledging the request, but left the amount at zero because I didn't put an amount in that decision package. I'm going to work with legislative staff on updating that final amount for their final House and Senate proposed budgets. The next item is one we've brought back to you for the last few years, which is around the benefits improvements for both the PEB and the SEB program. This year, we did request some small amounts for increasing the employer-paid long-term disability and the life insurance benefits. Either of these items, if they were to be picked up in the governor's budget, would be small enough that we wouldn't need an increase to our overall funding rate. So small enough to not trigger an increase in the funding. As you'll recall, last year we did submit a decision package on increasing the employer paid long-term disability, and that was funded in the last budget. So we went from a $240 benefit up to a $450 benefit, and this decision package would look at further increasing that to $650. As well, we looked at the life insurance benefit and put forward a proposal to increase from $35,000 to $40,000, but neither of these items were picked up in the governor's budget. So those were the two small items, being aware of the budget, the small amounts that we did recommend moving forward into a decision package. The next one, I think, is where we're going to pick up Dave's breadcrumb he mentioned earlier, which is around the decision package we submitted regarding the fully insured procurement. At the end of the last board session, we had a pretty lengthy conversation about what it would look like to bring additional fully insured carriers into the PEB program and what that type of procurement would look like. So we did move forward with a decision package. However, in the governor's budget, it was renamed to Benefits 24/7 Enrollment File Functionality. And that really was a signal that we needed to focus the funding on project management and support for enhancing the state's Benefits 24/7 system, our enrollment system, and really get that ready and advance our IT infrastructure for setting us up to be in a really great place for onboarding new carriers before a fully insured procurement. It was fully funded. In fact, it was funded at a slightly higher amount than we originally requested, which is really great. Our IT infrastructure and the funding request around that is really a top priority of our agency, and we're really thankful for this funding. We received $1.8 million per program, so 3.6 total per year for the next 3 fiscal years. And Dave, I'm going to pass it to you for your breadcrumbs.
Yeah, I'm going to do a snack because the meal discussion is really at the end of the board meeting, because between my snack and meal descriptions, we have Jean and Travis coming up to talk about our progress on and planning for Benefits 24/7 and Pay 1 changes. But this, this was the kind of the hottest topic we left off last board season. We had indicated that there didn't need to be action by the board to move forward with looking at some sort of procurement for the medical side of the portfolio for both PEB and SEB, and both boards had a very strong interest in wanting the agency to pursue this type of work. At that time, I had said the very next step would be you would see an analysis of the resources the agency identified as needed to be able to proceed with the procurement, and that there would be a decision package. So check, we did that. I actually sent the board in the off season in September a copy of the decision package right after it was submitted, so that you're aware that that overt step had been made. And then we went through the process with OFM and the governor's office, answering questions around it. And that really led to a common understanding of the criticality of IT work that needs to be done. So I'm going to let Travis and Jean describe some of that work and then pick up what that means for timing of a fully insured procurement in the last presentation of the deck. But any preliminary questions right now?
On the next slide, we're going to move away from decision packages and just do a little pit stop on some additional items that were included in the budget. I'll preface this with saying neither of these items on this screen directly impact the PEB and SEB programs currently, but we'll take a little step back to last year just to do a little reminder of how some of these items played out through the session last year and how they wound up impacting the program. So last December, Governor Inslee put a freeze on some of our non-essential spending, travel, purchasing of non-essential goods, certain contract extensions, things like that. That was in December. And then when Governor Ferguson took office in January, he directed actually agencies to come up with some additional budget reduction scenarios. We walked through those with the board. There was quite a lengthy list of items that we put forward as potential options. And of those, what was included in the final budget were things like reducing our premium stabilization reserve. So we freed up some reserves to put one-time downward pressure on our funding rate. We also freed up some of our long-term disability employer paid reserves that had been sitting there that we deposited into the general fund. As well as the legislature directed us to close the UMP Plus plans at the end of the last calendar year, which Alyssa talked about some of that switching. And then also the ending of the wellness program as of the end of 2027. So what you earn in 27, as a reminder, will be paid out in January 2028. But as part of the budget and the outlook and the savings booked, it was for the elimination of the Smart Health Wellness program. In addition to that, we did take a 6% administrative reduction on our PEB admin account. So the account that pays for our salaries, our portion of the building rent, some of our printing costs, things to really support the program. You might remember back to the little slide I had that showed kind of all the funding buckets last year and how the funding flows from the funding rate through to our various accounts. And it was just the one little bucket that did take that reduction, and it's targeted really at our agency's admin, not the admin for our third-party administrators or our claims accounts.
And that 6% administrative reduction was across state government. And last year it did expressly include the PEB and ZEB accounts because there are, this is the distinction Tanya is about to get into, but there are different shades of money in state government. There's general fund, there's money that's mixed with federal funds. And so depending on what the dollars look like, impact whether it is sometimes affected or not. Last year, it was across the board, all administrative accounts, including our PEB and ZEB accounts. But
it's always, when we're looking at these things, kind of a gray area whether the PEB and ZEB funds will be included or not, because typically when they're looking at balancing the budget and looking at currently the deficit, it's a general fund deficit. It's not all of the other accounts. And when we kind of put all of the dollars into the washing machine for the PEB program, we're less than 50% general fund, actually. So all the dollars that flow to us, so UW's funding rate, the funding rate from HCA, who has a lot of federal employees, federally funded employees, when all of that kind of washes out, the total funding to our program is less than 50% general fund. So all of that to say, the dollars do impact general fund, but our technical line item is not general fund. So there were two items in the current supplemental budget included for similar type reductions. However, both of them on the screen in its current state are based on general fund, so they would not impact PEB and ZEB. But I did want to bring them back because, as I just mentioned, things kind of evolved last session from, Governor Inslee's directive to Governor Ferguson and to the final budget, things that came through that did ultimately impact the program. So there are line items in our HCA budget, in the supplemental budget, that would reduce admin spending, but those are tied to the general fund accounts, not the PEB and ZEB accounts currently. And then there is also what we call the back of the budget in the 700s in the section in the back of the budget. There's one bucket of $11.7 million that is directed for the OFM to find in terms of WMS and EMS salary reductions across the state. There's no specifics on how that would be handled. The dollars were calculated based on general fund salaries. So if this remains in the legislative budget, and if the legislature doesn't put any further directive in the budget on how to approach this, the Office of Financial Management would give agencies directions after the budget. So I think these are still TBD. There could be a lot that changes with these, but I think the point really of this slide is to just say, we're still looking at possibly further reductions within the PEB and ZEB program. On the next slide is the funding rates. So the first year, because we're in the first year, the 1333 remains unchanged. We don't change a funding rate mid-year. However, the second year, the 1337 that's on the screen is changed. It's actually reduced from 1,350 from the enacted budget. So it's brought down a little bit. And really the nature of that is just the timing. We were sitting here a year ago when the legislature put these funding rates in the budget. So that was a year ago of claims experience, a year of trend, a year of pharmacy trends biosimilars coming onto the market. There's been a lot of changes in that last year. So the legislature always uses the most latest and greatest model. So I'm actually delivering another model here this next week that will inform the House and the Senate proposed budgets, which will just have that one additional year of experience, which will be different than what was used to inform the governor's budget. Again, the funding rate is paid per employee per month and includes the funding for the entire program. So for every employee's medical, dental, vision, life, LTD, any of our decision packages and things like that are included within the funding rate. The next slide is just a note that the Medicare explicit subsidy in the governor's proposed budget remains unchanged, and they maintain it at $183 or 50% of the premium, whichever is less, for calendar year 27. And that is my last slide. So like I mentioned, a lot could change between now and the final conference budget. When we're here at the next board meeting, depending on when we receive that final budget, it may be a verbal update or we might have slides, but we'll give you the most latest and greatest at that time. Harry.
Yeah, thanks for updating us on the 2027, because my view, that's more than a little bit, it's a significant hit. So I see there's going to be a lot of discussion. I anticipate we're going to have a lot of discussion this year when we come around to the premiums and all that, because it doesn't keep up with going from 1333 to 1337, despite some of the things that have been cut out. There's going to be some increase in pricing costs of goods and services, utilization, all those kinds of things that we really probably don't have a real great feel for right now. I don't know if I'm making any sense, but
I think there's one area just to make sure that you're clear on, because I want to make sure that the reduction from 1350 to 1337 is not any indication of reducing benefits or the board having to come up with additional dollars. It is really about the fact that we are just one more year closer to fiscal year 27. When we were sitting here this same time last year and we were working with the legislature to set the funding rates, the board hadn't even adopted the 2026 rates yet. So yeah, so we update projections every single quarter. And because the fiscal year 26 1333 cannot be changed, this second year, reducing from 1350 to 1337, is catching up with positive claims experience we had from fiscal year 25. Also, what's happening in fiscal year 26 and projections all the way to 27. So it's 3 years worth of accrued savings, positive claims experience. We might have procured rates slightly under what we had built in the original budget last year. So all of those items come into us trying to get to a closer fiscal year 27 projection. It is not a sign that there is any work for the board to do on reducing costs. This doesn't include any underlying cuts to our trends. In fact, the 1337 is the number that I recommended for status quo over to the governor's office.
Thanks. That's really reassuring to hear.
Yeah, sometimes people see it. My mother-in-law works for another agency, doesn't understand, and she's like, "You're cutting our benefits," and I have to explain this. That no, it doesn't mean it. It's just catching up with trend.
Yeah, I guess my overreaction, if that's what it is I don't have any issue with the UMP. I have total confidence in the projections there, but it's some of the fully insured where we've seen this whipsaw, trampoline, whatever you want to call it, up and down. And but
remember,
we just have to see where we are.
The state costs are not impacted by the whiplashes of the fully insured premiums. The state costs are borne fully by the uniform medical plan, because the state's collective bargaining agreement says that the employer contribution will be 85% of UMP Classic, no matter where you're enrolled. So if you're enrolled in a Kaiser plan or on SEB in a Primera plan, those increases then are fully borne by the employee in those plans, because the state's change is based on UMP. Yeah.
Just reinforcing that this is what Tanya was describing about 1337 doesn't convey any intent is the embodiment over the years where Tanya has said there's no magic number. Don't focus on the number, focus on what we say is underlying the number that you can't see in the budget. 30, I think it's really important when Tanya said, 1337 was the recommended status quo based on the model that was used to create that number for that budget.
That might not be the case with the legislative budgets. The legislature, it's totally within their right, and they have the authority to set the funding rate at a different level. They might want to have less conservatism in maybe some of our trend projections or some of our other underlying assumptions. They might want to take more risk on the program that year, and that is something that they do. And sometimes they'll overfund it or they'll underfund it, and we usually don't have too significant of concerns with that because really then it's really up to the legislature the next year to kind of bring us back to whole. So yes, Dave says no magic number. This is the magic number that I proposed, but we'll see what happens.
That's yesterday's magic number, but there's no ultimate magic number.
Yeah, but we'll see what happens.
Yeah, I wasn't trying to fact check you, but when I saw that number yesterday, whenever I looked at this, I said, there's something different here. And then I went back and looked at last May, the rate was 1350.
Yeah.
And so that's why I went into a little bit of a panic mode, is not seeing the big picture.
Yeah, a lot changes.
We're losing money.
Quarter to quarter, we can see $40 or $50 million swings in our program.
So I have another clarifying question. I'm getting good at clarifying questions. So the 1337, 1333, 2026, 1337, 2027. So that is per state employee or per state employee. So if you take 302,964, which is what we currently have in the PEB program, and you multiply that times those numbers, then you get what the state contribution is?
No. I think an important piece is the funding rate is paid per eligible employee.
Yes.
Benefits eligible. That is different than who's enrolled.
Gotcha,
So the funding rate is paid even if an individual waives benefits.
Yeah.
And so it's about the total eligible population, not the enrollment.
Yeah. Okay. Thank you.
Correct. Those come out of the agency budgets. And in the case of PEB, there is something that's done in the spring. It's called a compensation impact model that every agency releases over to OFM and says, this is the number of employees I have, the positions, how they're funded. And then when things change like this, and we have a reduction in the funding rate, there will be a line item in every agency's budget, in the governor's budget, to show them pulling back the funding from the difference between the 1350 and the 1337 by fund source, recognizing employees are all funded from different fund sources. Anything else? Okay.
Thank you so much, Tanya. And much more to come on the conversation with Travis and Jean once they are after lunch on sort of the IT infrastructure, but and I'll save and preserve my comments for then just how important that is just for the overall larger agency and the broader impact of what we're thinking about HCA for the future too. So with that, we are at a portion where we are going to go to a break. We're going to convene here at 12:35. I think is where we are, and we're going to have a working lunch at that point. I think lunch is here. People can get their lunch, and we'll have a break till 12:35.